Bruce, you must have something really good too.
Of course I do. It's Bruce Danielson, and I guess I'm here to entertain you too.
All right, good afternoon, everyone. Welcome. I'm probably going to end up taking this down while I talk and putting it back when I'm not. Welcome to our special Sioux Falls City Council meeting. Appreciate those of you who are here. We have a very limited audience in the room. We have, I'm sure, a lot of people joining us online as well. Kind of to call the meeting to order, I'm going to ask for the roll and the Pledge of Allegiance like we normally do. I want to go through a few housekeeping items here. You know, per council policy, public comment will be taken after each staff presentation today. So we have 3 of those. Those will be limited to no more than 5 minutes. People are asked to keep
joined the meeting.
People are asked to keep their remarks limited to the item that's being presented. I ask the audience to observe social distancing to the extent possible. I will ask that speakers not touch the mics on the podiums. Also, the chairs are spaced 6 feet apart. I ask that you leave them there and not move them into the chambers or not move them in the chambers or in the overflow room, please. I want to remind you that those in the audience and those watching at home, that all meetings can be viewed on Midco channels 16 and 594, and on VAST, you can see us on 11 and 511. Additionally, you can view a live web stream at siouxfalls.org/live. Lastly, some of today's presenters will be joining via video conference rooms that are set up here in Carnegie Town Hall and at our Emergency Operations Center. There continue to be 3 council members joining electronically as well. So we're doing our best to facilitate social distancing here at the dais and in our seating areas. So that will get us started today. Tom is clerking behind me here, and we'll ask him to get us started by reading our roll.
Councilmember Selberg.
Here.
Sale.
Yep.
Starr.
Here.
Staley. Brecky.
Here.
Erickson.
Here.
Kylie.
Here.
Neitzer.
Here.
All right, I'd ask that you stand for our Pledge of Allegiance, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, so again, there'll be no actions taken today, no votes taken. This is just a special meeting, but for informational purposes only. Our first topic is to get an EOC update, and I'm going to ask Regan Smith, I think, is leading that, or Jill. Jill's leading that, so I'm going to invite Jill forward, please.
Good afternoon, everyone. Jill Franken, Public Health Director with the city, and I'm only going to just give you a little bit of information before I hand it over to Regan. First off, I want to thank Tom Greco after Wednesday night's council meeting. They've made a lot of changes in here that I think were important changes to make, and so him and the team of the city that really took some time to creatively think about how we can conduct business of the city and still be safe, I think is really good, so thank them for that. Just to give you a quick intro here, just want to remind us that we had 93 new cases today in Minnehaha County of COVID-19 infections. We had 6 new cases in Lincoln County. So total in Minnehaha County to date is 1,157, and Lincoln County 77. That equals 1,234 cases in our 2 counties. One of the things that we've been working on, I've talked to you about our operational objectives for our incident action plan of the Emergency Operations Center. We have been working this week to revise those for this next operational period, and I think it'd be good for you to know what those are going forward as we continue to move through this response. This has been with input from our EOC leadership that includes Regan and Sandy as those emergency managers that really monitor and manage the EOC, as well as Unified Command has reviewed these and then have had these reviewed and edited as necessary by our city leadership, which has also included our city directors. So As we move forward with this, the work that we're going to be doing, the first objective is really to review, assess, and implement the public health measures necessary for COVID-19 management. The second is to coordinate with healthcare agencies to support and expand their services and capacity. The third objective is to provide coordinated and proactive public information about COVID-19 facts, risks, and protective actions. So a lot of that we've already been doing. We'll continue to do that. Fourth is to coordinate strategies to manage economic impacts to the Sioux Falls community. Mayor Tenhaken has talked about that quite a bit, that we have to start thinking into the future while we're operating under this pandemic right now, and so that's work that will begin in this next operational period. Number 5 is to execute and adjust City of Sioux Falls department continuity plans to ensure continued essential functions can be maintained through various phases, including mitigation, surge, peak, and recovery. And then lastly, to assist organizations that serve, but certainly, it's last but certainly not least, is how do we assist organizations to serve the most vulnerable and at-risk populations in our community. So that's gives you a sense of where we'll be heading next. Those are big objectives, and there will be tasks under each, and those are the things that we'll continue to be rolling out as we start next week, really moving into this next operational period. So with that, I'd like to turn it over to Regan Smith, who's our emergency manager for the city, and he can give you a review of the EOC. Thanks.
Thank you, Mayor, Council. Appreciate the opportunity to give you this overview. This is something we wanted to present over the last couple of weeks, but you've been dealing with important issues, and now is a good time. The COVID-19 planning team was developed and met regularly and started sharing information with our community partners in late January. Our City Emergency Operations Center has been open and operational since March 13, so that's 41 days to date. Consistent with other responses in the city multi-agency coordination team is supporting this response from our Emergency Operations Center. This team is conducting daily operations briefings with over 40 community response partners. We issue a daily situation report. 41 of the reports have been developed to date. We've developed an incident action plan, and that is updated very regularly with those new objectives and operations. And as Jill said, that unified command is setting objectives and priorities. You can look at the org chart, and I apologize for the print there, but it's a big organization, so that's what we've got to look at today. As you look at it, our unified command is made up of our City Public Health Director, Jill Franken, and representatives from Avera Health, their Chief Medical Officer, Mike Elliott, and Sanford Health Chief Medical Officer, Mike Wilde, and it's been a great relationship. They're being advised by public health advisors from South Dakota Department of Health, the City Health Department, and then epidemiologists from Sanford and Avera as needed. Under that, we've got our PIO, and we've developed a joint information group that's made up of the City EOC, the South Dakota Department of Health, Sioux Falls Public Schools, Sanford and Avera Health Systems, the Helpline Center, Bishop O'Gorman High School, the VA Medical Center, Lifescape, Patient Care Logistics Solutions. They're developing our daily news briefings, our press releases, social media infographics, our website, educational posts, as well as answering those direct inquiries from the public. We've also activated the Helpline 211 Center to assist with calls for this information, and again, they're an invaluable part of our response, and they're also leading the efforts for the Unmet Needs Committee in the community. Our liaison officer, which I'm at that role for this incident, is working with agency representatives from Minnehaha and Lincoln County, the court system, Chamber of Commerce, South Dakota Department of Health, Sanford, Avera, the VA, South Dakota National Guard, Sioux Falls Public Schools, Bishop O'Gorman Catholic School,
has joined the meeting.
Sioux Falls Christian, Harrisburg and Brandon Valley Schools, and communities within Minnehaha and Lincoln counties. if we move into the operations there on in the red, we've got that divided into 5 groups. The first group is the Sioux Falls Healthcare Coalition, and this is a group that was formed probably about 25 years ago, and it's made of the City Health Department, Avera Health in Sanford, and the VA, and State Health is also working that. That group is dealing with such issues as increasing our hospital surge capacity, development of a possible alternate care site, inventory management of PPE and other critical items, specimen collection sites, and then housing of isolated and quarantined individuals. The work involved in the management and finance of all these projects is really extremely complicated and continues to grow as this incident develops. Second group is our public safety group, and that's made up of our police, fire, EMS, and 911 system. They've developed and implemented enhanced mitigation and response protocols, additional personal protective equipment, and additional EMS vehicles for our 911 and EMS responders so they can protect the health and welfare of the public and responders. This group's put considerable effort in developing a mechanism to be used to provide our first responders with information to help them manage potential staff exposures. This group is involved in partnerships with the South Dakota Department of Health, the Sioux Falls Health Department, the Fusion Center, and a number of law enforcement and fire and EMS agencies. Moving ahead, a third group is our City Continuity of Operations group. This group is working with all city departments in implementing their continuity of operations plans to continue those essential government services while providing the health of their employees as they serve the public. COVID has really changed how every city department is doing their business. A great percentage of the city effort is now dedicated to COVID preparation, mitigation, and response. Vulnerable Populations group, and that's being led by the Sioux Falls Health Department along with Minnehaha County Human Services. They're working with our housing division also and hospital case managers to assist with sheltering needs and meeting needs of vulnerable populations as they quarantine and isolate. City and county are working with local support agencies to ensure the homeless populations are supported and sheltered. And again, that's a growing and developing group that's working hard. Continuity, Community Organizations Act in Disaster. You've heard a lot about these folks. They're coordinating relief efforts for residents through that Sioux Falls Relief Fund, One Sioux Falls Relief Fund, Unmet Needs Committee, and then community food distribution. Finally, we have city inspectors from Health and Planning Services that are proactively assisting businesses with education on mitigation efforts that include such activities as conducting employee screenings, increasing efforts on environmental cleaning, and high-touch surfaces. Those are the operational things. We also have a planning section that is helping us develop situation reports, our incident action plans, and then doing all that work with that data analytics that we're going to see here shortly. And then our logistics section, which is primarily our finance department, is procuring PPE, developing contracts, and securing other resources as are needed, not only for the city, but other response agencies within the community. With that, again, I appreciate all the support of the leadership here at the city, and take some questions now if anybody has any.
Thanks, Regan. I'll first ask if there's anyone from the public who wants to talk specifically about our EOC, not about any ordinances. All right, seeing none, no comments on that from the public. Councilors, you want to ask any questions of Regan or Jill on our EOC setup? Councilor Staley?
Do we have a
Mr. Mayor, first of all, somebody's not muted and they're creating a lot of feedback. So if they could mute their phone or stop working near the mic, that would be very beneficial.
All right, thank you. Councilor Staley?
Is that better, Councilor Kiley?
Yep.
Yes, it sounds better now.
I don't think it was on our end.
Thank you.
Okay, so a question that I've got is, Reagan, these slides here, do we have a copy of those?
I'll work with
Tom to get those to you.
Counselor
Yeah,
Staley.
that would be beneficial to have that. And then I was just wondering about a name on the first one, Jeremy Cowells. What, I haven't heard about him.
He's a physician, he's working with,
And what institution is he with?
he's with Sanford Health.
So, okay, because the other two, Avera and Sanford, we've heard of, but I didn't know there was an extra one. Okay, thank you.
You bet.
Other questions for Regan? Any questions on the phone for Regan?
I've got one more question too.
You're on.
And then how's the VA playing into this? I don't know if you're the person to answer that, but we're hearing a lot.
They're part of our healthcare coalition, so they're increasing their surge capacity, and that's part of the overall plan that they can take. Obviously, their primary mission is veterans, but they also have another mission where they can take patients outside of their system if needed, and we're working with them daily and making those plans in place.
Would we ever have a necessity to have them come in and be represented here physically like we have the other two hospitals? I mean, do they have a chief medical officer as well?
So the VA is part of our healthcare coalition, but the provider, the physicians who are here are actually with our unified command. Jeremy Cowells has been helping assist if for some reason Dr. Wilde is unable to attend a call. But it's really been primarily Dr. Elliott and Dr. Wilde who've been in our unified command, with Dr. Jeremy Cowells helping in that capacity as well when needed, and so that's why they're here.
Okay, so would Avera ever have someone else stepping up to be, I mean, we've got two from Sanford, would we ever have another one from Avera as well?
We do actually, I mean, we made the decisions that we did regarding unified command, but Dr. Basil is also here on behalf of Avera, and he has been extremely involved in some of the work we're doing around the modeling, and so that's the answer I can give you on that.
Yeah, I think, Counselor, also I could say the VA is more an operational resource that we're working with and less at the unified command level here in this organization. But we are working with them every day, and they're integrated into the system.
Good, and I know the public has asked about how the VA is playing into this whole operation. Thank you.
Other questions for the EOC team? Any questions on the phone? All right, thank you, Regan. All right, we'll move on to our next item. This is, I think, what most people want to talk about, our data modeling review. To kick this off, I'm going to actually pass the gavel to Councilor Selberg, because I want to be able to speak to this one today as well.
Has left the meeting.
Someone's sick of it already. On Wednesday night, our administration brought forth a stay-at-home order for first reading to you as a city council. This proposed ordinance was brought in response to the rapid case growth and spread of COVID-19 in Minnehaha and Lincoln counties. More importantly, it was the result of the data we have been reviewing that showed our healthcare systems could be operating at or above capacity during our peak, which is currently forecasted for mid-May. At that meeting, we discussed how rapidly this situation changes, how data forecasting continues to play a primary role in our response, and how 5 days between a first and second reading can seem like 5 years in this current landscape. This situation and the warranted responses change like nothing I have ever experienced in my professional life. We are in an environment where we as local governments are being asked to be nimble in a system set up to be anything but. Noticing meetings, holding first readings, holding second readings, providing time for new laws to take effect. It's made managing this pandemic at a local level very, very challenging. This morning at 8:30, our Emergency Operations Center, we received an in-depth modeling briefing from the City of Sioux Falls data teams. This data presented is a joint effort of data, information, and assumptions from the state, from Avera, and from Sanford Health, specifically for Lincoln and Minnehaha counties. Again, that's really important. A lot of what you've heard from the state level is state data. What we're going to be sharing you for the first time ever is data specific to our two counties, which is harder to come by than one may think. The council and public will see that same presentation here shortly. In this presentation, you're going to see two key themes emerge. One, social distancing and mitigation strategies have a direct impact on peak hospitalization numbers. The more you do, the lower those numbers. And two, at our peak, again, currently forecasted for mid-May, our healthcare systems, while operating at maximum capacity, feel they can meet the current COVID demand. This is important information to understand as it creates an opportunity for us to determine what measures we can deploy to further flatten the curve and provide our healthcare partners with more of a capacity buffer, while also providing the needed support to the businesses and employees of our community who continue to be impacted by this pandemic. When we alleviate the hospital capacity, we help ensure that life-saving resources and caretakers are available to those who need them when they need them. Remember, we are not stopping COVID. Okay? The reality is people will die from COVID-19. All right? People will need ventilators. People will need ICU beds. People will need to be isolated from their family members. This is a reality that we all need to face, and everyone needs to come to terms with that. What we are tasked with as government leaders is to try and control who gets sick and when, and minimize community damage during that process. It's a near impossible task with no winning playbook, but there are, however, some smart plays that we can call based on the invisible COVID-19 opponent that we're currently facing. Council, I would ask you to review this data here today with a very open mind. The administration's view on what you are about to see is that our current stay-at-home order that you will hear a second reading on Tuesday needs to pivot. Based on today's data, I feel that the measures we still have to take in our city to further flatten our curve can be enacted through enhanced regulations in our existing no lingering ordinance and not via a stay-at-home order. We are currently working on what this could entail, but would likely involve measures to target where the population density is highest through mandatory mask wearing potentially at public businesses, mandatory temperature checks for large employers, large companies, or other potential measures. As we have said throughout our response to this, the city and our administration is relying heavily on our healthcare partners who have been incredible, by the way, and strong data modeling in our response and will continue to evolve as we go. All that being said, public health and protecting lives has been and will continue to be my number one priority in this response. I'm going to read that again. Public health and protecting lives will be my number one priority throughout this entire response. There's no greater duty for an elected official than to protect the lives of the constituents he or she is serving. That is what drives me right now. That is what keeps me up at night. That is why we are sharing with you the data we are going to share today. I am thankful for the sacrifices of every single person in this city and the steps they've taken to flatten our curve and save lives. We have a large number of cases in the Sioux Falls area based on hotspots, as well as more aggressive testing than any other areas of the state and nation. Regardless, the virus is here. Hundreds have confirmed cases and thousands of asymptomatic people are likely present in Sioux Falls right now. Let's be clear about our ultimate goal here. We want this virus gone with minimal damage minimal deaths, and minimal impact on our economy. Sacrifices have been made, and sacrifices will continue to be made in the weeks ahead. We are in this pandemic together as a community. We will prevail through it as a community. Each of us has a role to play, and as a city council, our role is to look at the policies impacting the entirety of our community on a macro level, on what's best for the entire community. I believe the actions we have taken thus far are justified in the proposals before us in the days ahead. They're very necessary for us to consider, to protect lives, but also to sustain this great city. And so with that as a backdrop, I'm going to turn it over to Eileen Proffer with our city GIS and data department to walk through the very detailed modeling we are using to make our recommendations to you today. So Eileen, you can come forward. While she's coming up, I just want to reinforce this is another commitment to the transparency of your city leadership. We're going to share with you more data than probably anyone in this room has seen on COVID and what's driving the modeling for Lincoln and Minnehaha County. So we will take questions after this when Eileen is done and move into conversation, and there will be a period of public input time for that as well. So Eileen, the floor is yours.
Mayor, if I can just interrupt one
Yeah,
moment.
Tom.
Eileen, can you use the one labeled clerk?
Got it. Okay, thank you. Thank you for taking the time to be here. I know that each and every one of you have a heart for the people in this community, and that we are asking you to ponder some very difficult decisions. As I walk you through the models today, I'll be talking a lot about numbers, a lot about data, but I'd like us to keep in mind that we are really talking about people, not infections or beds or ventilators. We're talking about family and friends and neighbors. So just to keep that in mind, and before I delve into the details, I would really like to thank you for your patience. I know as we prepared this information, it's not easy to wait for numbers, but several teams have been really working around the clock for weeks to get where we are today. And I want to acknowledge the commitment that we have seen dedicated from like highly capable, intelligent individuals from Avera and Sanford, the city and the state. It's been a long week, but we have been able to work together to get where we are today, and I'm very happy to acknowledge these individuals that all came together to bring us to where we are today. So our goal is to share with you where we're coming from a public health perspective. I will show you the model that was created here at the City of Sioux Falls, and I'll give you a detailed explanation of the parameters that went into using that model. And after that, the doctors from Avera and Sanford are welcome to comment as well. I'm sure there'll be questions, but I'll try and get through all the parameters first, and then just so keep it in your head and hold on to it. If you really need to ask something, feel free. If at any point you need me to slow down, please just say so, because I've been doing this presentation over and over, so it feels like, you know, it's easy for me, but I need to slow down sometimes. So if you can't hear me, just let me know. So I'd like to begin with an image that you're probably all familiar with. It's that flatten the curve graph, and it really represents the impact that social distancing can have on the progression of infectious disease, and nicely illustrates the risk of fatality from overwhelming our own healthcare resources. But I know it's still rather abstract to look at it, right? There's actually no real numbers on it, there's no real timeline, and that's really because flattening the curve looks really different depending on your own local circumstances, which is why it was so important for us to be able to use Sioux Falls or Sioux Falls area local data in our modeling. So keep in mind that graph, that's pretty abstract, and now we can throw in what the models show that we've accomplished so far in terms of flattening that curve. So what you're seeing are the curves produced by the model that we used, and it shows in that kind of, gosh, I don't know, orangey color, where we could be right now if we had not implemented any social distancing. And it also shows the current trend of around 25% reduced social contact in that blue color. and that's where we are trending for expected peak infections. There is a vertical gray line that you can see. It says today on it. That is literally today. And if we hadn't implemented any of the interventions that we have in place right now, this would be a totally different conversation today, because we would be looking at nearly 600 hospitalized COVID patients. So we can pat ourselves on the back that we have already accomplished a lot. And as good as this graph is, it surely can be better. Even at our expected peak in the blue, if we continue on that same blue curve, we're walking a fine line of the quality of care that can be provided at that level of illness in our community and along with the communities around us who depend on our healthcare systems. So we also used our model to project a 35% reduction in social contact, and that's the green curve that you see. And that really puts us at a much more comfortable situation to be equipped to handle the surge of COVID patients. So this is slightly less abstract than that first flatten the curve graph. Yes.
And I,
Sure. Okay.
there you go.
Right on the blue line now.
Get as close as you can, yeah. We'll give you some grace.
Thank you. Right, so this graph that we're looking at is slightly less abstract than that first flatten the curve graph, but now we've got some numbers and we've got a timeline to go along with it, but how did we really figure all of that out? So the curves that you're seeing are based off of a commonly used technique for modeling infectious diseases. Unlike COVID, those methods are not novel. They have been in use in some form or another for nearly 100 years. And in a very basic way, we can understand the progression of infectious disease in terms of 3 groups of people. So you have those who are susceptible, those who are infected, and those who have recovered. At the beginning of an epidemic, right at the top where it says susceptible, everyone is susceptible to the disease. There's no vaccines, anyone could get it. And once people become exposed, they move out of that susceptible category into the infected category. And as more people become infected, less and less people are able to be susceptible because they either have it or they've recovered from it. So that is the process that creates the peaks that we've been looking at in all of our graphs. So you can see in the blue where it says infected, that is the peak that we are modeling basically. And that is a very basic, very, very basic explanation of how the models work, because really all models are simplifications of the real world, and really the real world is much, much messier than 3 groups of people that move smoothly from one category to the next along a perfect curve. And we have to take into consideration a whole lot of variables that can be difficult to quantify, especially with a virus that's so new. So for that reason, we say that our models are dynamic, and that means that they really do continually need to be reevaluated as new information becomes available. So we see what's happening on the ground day to day, and we make adjustments. But models are really important tools. They're important for planning ahead and thinking about the actions that we need to take today in order to reach a future goal, while avoiding any catastrophic branches that would lead us down a path that we just don't want to have to go down. So because they take so many parameters, we're going to go over what this model in particular looks at. And I'll try not to move too quickly. If you do have questions, here's a good place to ask me. So
Eileen,
greater detail.
I'm going to ask you actually, why don't you just come forward? It's not picking up the audio very well, so we're going to give you a hall pass to move forward a little bit. So if you sneeze, don't sneeze at me. You just sneeze down and.
Sneeze down.
All right.
Okay.
Go ahead.
Maybe it's because I'm looking down. Sorry.
No problem.
Okay, so for the first parameter that we have there, it's population size. So we are considering the population in Minnehaha and Lincoln County. Is this better? Okay, good. This one, because I'm so short too. Okay, there we go. I'm going to eat the mic now. The number of currently hospitalized, obviously that fluctuates from day to day, but we had to pick something, so 40 was the number that we chose. The date of the first hospitalization is basically the start of our modeling. We start March 20th, which was when at least Avera had their first hospitalization. The next three parameters that you see there, the hospitalization rate, the intensive care unit rate, and the ventilation rate, are they follow the rates that are stated in scientific literature, basically. This is probably the most complicated part of the model, but in our conversations back and forth with the healthcare providers as well as with the state, an acceptable range of between 0.5 and 1% of total infections was chosen to represent the hospitalization rate. So we picked a kind of a middle ground there at 0.8%, which may be slightly above what we're actually seeing at the moment, but it seems fair given the range of 0.5 to 1%. The model also takes into account the number of days that a person is infectious. That means the number of days that they could be spreading the disease, whether they know it or not. They could be, in general, I think we're seeing that you might be asymptomatic for 5 days, and then you start presenting symptoms. The average lengths of hospital stays, those obviously are numbers that the city, the city GIS department, we don't exactly know because we're not in the hospital system, but we use the Department of Health from Minnesota, which is regionally very near to us, and they publish their numbers. And in conversations back and forth with our health system and with the state, again, these numbers are not unreasonable. A hospital stay length of 13 days, 10 days in the ICU, 8 days on the ventilator on average. And the nice thing about this model is that they do have a parameter where you can take into account a percentage of reduced social contact, so social distancing percentage. We ran our model through 3 scenarios, one with no social distancing, one with 25% social distancing, which we consider to be what we're doing right now, and 35%, which is what we estimate could happen if we continue on with the stay-in-place ordinance that could take effect on April 24th. So running through those models, if we take a closer look, that first top really big spike there is what would happen, what we could expect to happen if we had not done any social distancing at all. And we would be peaking in just a few days here, but the number of cases, the number of infected population, that's what's on the vertical axis there is the infected population, would be very high, 110,000 around. And then the second blue peak is what we consider to be doing right now with a peak May 21st. If we start a 35% reduction in social contact on April 24th, we can expect that green curve to take place, and we would peak around June 4th. In terms of the stress that's placed on our healthcare system, the next 2 graphs are relevant. So the top, or the blue line, is our hospitalization census. So our model gives an estimate of how many hospital beds we would need. And that would peak on May 19th if we continue at the 25% social distancing, and ICU beds on the 17th and ventilators on the 16th. But the graph on the right is what it could look like if we implemented 35% social distancing. So just 11 more days, but the peak is reduced nearly in half. And I'm sure that would be much more comforting to our healthcare systems to know that they would need half as many resources to care for the surge that would be coming. Okay. So this is just in table format, the same charts that you were seeing, but basically tables. So if we had no social distancing, April 27th would be our expected peak with a number of infected individuals at 109,000. And the peak healthcare day would be April 25th, which is not that far away, but they would need 924 beds, which I don't think we are at that capacity yet. ICU beds at almost 190 and ventilated 115. So the next column over is the 25% reduction in social distancing, which I think we are doing right now, and it puts us at a peak of May 21st with 77,000 infected. And the healthcare systems would basically be at their max capacity on May 19th with 200 less beds needed and 143 ICU and 87 ventilated. The very last column is our projected 35% reduction in social contact, peak June 4th, but with 40,000 infected, which is considerably less even than the 77,000 that we're expecting now. The number of beds could go down to 330, ICU 64, and ventilated 39. So I'm sure, because it occurs to me, that the next question you have is, how do we know that our current social distancing percentage is 25%? Well, that is an estimate, but we do use several different sources. So one of those sources is our own traffic count data that measures the number of vehicles traveling through 5 of the intersections in town, and it suggests that there's about 30% less traffic at those intersections. And another source that we have been, at the city, have been consulting is data from a marketing and an analytics company called Cubic. And this company tracks cell phone data they have a private network of partners, and where all the users have opted in to share their location data with this company. And the data remains anonymous. There is de-identification and large-scale aggregation of their data prior to any publication. And they offer that location and data free of charge and openly in response to natural disasters, urban development projects, and in this case, disease prevention. So for each county in the United States, they have released to the public a percentage change in mobility over the same period of time last year. And the GIS department has been tracking that information to consider in our estimate of social distancing. So I'm going to share with you another graph. This one is a little bit busy. It's kind of a lot to look at first, but I'll take the time to walk you through it in detail. So the blue bars here that you see are the total number of cases that we've been tracking since March 10th, which was when we found out of our first 5 cases in the state. And this is the number of cases in Minnehaha and Lincoln County. So it's not total state numbers, it's still just in our area. The light bottom blue on the bars, that represents the number of new cases that we're seeing every day. And all those little notes that fly out are the events that would be significant to our mobility or the progression of the disease. So things like, well, we had 1 death and 5 cases. We closed our offices. We had the no loitering and gatherings limited to 10 people. That type of thing, those are the notes that are popping out there. Those big dips that you see, so the orange and purple lines, are the percentage change in mobility for Minnehaha and Lincoln counties over the same day, but a year ago. And their data actually does lag behind a few days, so that's why it doesn't go up to today. It's kind of stops short on like I don't know, maybe the 13th there. But in the beginning of March, according to Cubic, our city traveled about the same, if not just slightly less than the same period in 2019. At the very top beginning of that line graph, we're just about the same. So the large dips that you see are weekend travel, and what we've really done well at is stay close to home on the weekends, and the data shows that we've been traveling nearly 70% less than those same weekends in 2019. So when we first started having put together our models, our mobility, and we discounted those weekends because they're just such gigantic dips, our mobility had decreased about 25% according to the Cubic data, and that data matched fairly close with our traffic counts, so 25 seemed like a pretty reasonable estimate to use for our reduction in social contact. So as you can see in the circled red there, from March 23rd through April 5th, that's about a 25% reduction in social contacts. So it is measured over the year before. But let's be honest, social distancing is actually really hard, really tough, and we did really well in those first 2 weeks. But the concern is, if you look at the red circle now, is that we are returning to near normal levels of travel between April 6th and 10th. So if you think back to those first graphs that I showed you in the beginning with the curves, it showed just how big of an effect social distancing has on flattening that curve. And one of the concerns that we have is that a reduction in the percentage of our social distancing at this point in time, especially as more cases start to emerge, that could really alter the trajectory of that curve and essentially erase the gains that we've been able to make up until now. So another great question would be, how did we decide that 35% would be representative of the stay-in-place order that we're proposing? So that data comes from research from the University of Pennsylvania, and they investigated what varying levels of interventions had on social contacts. So on the very left, you see interventions. School closings reduced social contact by 4% for them. But the impact of that 4% less social contact ended up being 15% less critical care beds needed than if they had not had any social contact interventions in place. Restricting gatherings to 10 or less people had a reduction of 15% in contacts, social contacts, but the impact of that 15% was a 42% decrease in the critical bed needs compared to if they had no social distancing. And basically that last category that they have is combining everything. So school closures, along with restricting to 10 people and having non-essential employees stay home, ended up in a 31% reduction in social contact, and really a significant decrease in critical bed needs, down 65% from if they had no social distancing. And in our graphs, through our models, we follow that a very similar trajectory. So school closings and restricting gatherings to 10 persons ends up with about 60% decrease in critical care beds needed. And if we include all non-essential employees staying home, that actually ends up being a 70% decrease in critical care beds needed from the non-social distancing category. So it goes to show that while social distancing isn't easy at all, it is effective. And I'd just like to go back to that. Our curves, our models, basically the blue is where we are at now, and the green is where we could be if we implement a 35% reduction starting April 24th. I think that's it.
Elaine, thank you.
Questions?
Thank you. We will have questions. First, I'm probably going to let you take a seat because we'll probably have some people who maybe want to speak to this or have comments on this item.
Do you want me to lead that part yet, or?
Oh, I'm sorry, I passed
that's
the
fine.
gavel. You're in charge. Yeah, go ahead.
If we have public input on this subject in particular, come on up. All right, we'll go to questions from the council. Oh, hold on, somebody's coming.
Standing behind the blue line.
Yeah.
Just talk loudly. That's fine. I wasn't here. I'm sorry. I just got here. I'm Bridget Myers, and I live here in Sioux Falls, South Dakota. And I am asking you to please pull the shelter at home that you're planning on putting in.
That'll be the next item. Is this for the data that was just, we're doing it item by item, so.
Okay. The data that was just pulled here, so I guess I just have a question then on it. Is that 35% then doing the ordinance that you're looking at? I was confused with the 35%, and is that what it is? Okay. I guess my question is, how come we have to show everything that's the most extreme? Do we have another model that shows a different version that would maybe be the minimum of what we're expecting instead of always showing the extreme on our graphs? Is there a way that we could show the minimums and the maximums? Because I feel like we only get like one version of what you're showing the public. There has to be more than just this model that can be shown. So my question is, if we're going to be presenting data, can we just present both sides, a minimum and a maximum? I also would like to see some economic impact that's happened, because I think we're at, what, 34 days that we've been in the stay-at-home order? I would like to see some data that actually shows the economic impact, that because the lives that you're trying to save from a virus is also going to impact people that can't pay their loans. The suicide rate that's going to go up in our city should be alarming to all of you, because people can't get loans. The money is out in the PPP loans. So I just want you guys to make sure that you're giving both sides of the thing to make your decisions.
Thank you. Come on up. And again, this is on the topic of data modeling that we just reviewed, so. Yep.
My name is Bruce Meyer, and if I see that chart correctly, is that modeling with 25% and 35% talking about 10,000 on April 24th, about 10,000 infections, and that's in the Sioux Falls area? Is that correct? Is that what that says?
I can speak to that.
Okay.
So yes, this is the number of infected population, and it is confusing. It's because basically it includes, it's not just confirmed cases. This is from the literature, the scientific literature. It includes people who are mildly symptomatic, who may never get tested, and also those people who are asymptomatic. And so how do we know that? Basically, we've had a few countries that have done extensive testing. So South Korea, New Zealand, Iceland, and incredibly enough, if you were on that Diamond Princess cruise, that was like a science experiment made in heaven. I don't know. Not great because people died, but they tested everybody. Like they maybe didn't test, I don't know, 100 people. They tested more than 3,000 people. And so it gave them a really good idea of those who had COVID but didn't know it. And so what we're seeing from those countries who are extensively testing everyone, whether or not they are presenting symptoms or not, is that that 0.8% is the number of total infections that will actually end up hospitalized. So it doesn't represent confirmed cases. So yeah, if you're looking at this graph now and looking at April 24th and thinking, oh, we should have 10,000 cases, that's not the case. That is 10,000 people who are likely infected, but it does not include, it is not people with confirmed cases right now.
Thank you.
And actually, it ends up being about 10%. So if April 24th around, so that's 10,000, it's about 1,000 cases. We're actually running a little higher than that right now.
Okay, so taking your numbers that say we may have 10,000 people in South Dakota that might be infected and not know it, our actual numbers are about 1,165 or 1,400 to 1,300, something like that in the Sioux Falls, not South Dakota, in the Sioux Falls area. And I dispute on the 25 and 35% models. I see most people in Sioux Falls having masks, having gloves, staying at least 6 feet apart. I have 100% social distancing for my grandchildren for the last 30 days. And I think that our estimate is way low on the social distance being practiced. And the other number that you had up there before was about 100 beds would be needed. So far, totally, we've needed 40 beds. And maybe 8 people in ICU. So what we're doing is either working, or the people that may have this infection are immune, have a natural immunity, and I think the models are something that are so abstract that we have to start looking at the actual numbers. How many do we actually have? And I don't think these represent that at all. I think we have much lower numbers actually and much higher social distancing based on everybody that I see wearing and using these and keeping their space.
Thank you. Anybody else with public input on this item? Welcome.
I'm Corey Hansen, and I'm trying not to lead into the next discussion. I am encouraged by one thing on this, that April 16th, and these pages aren't numbered, but on one of the graphs, which he showed, the cases actually went down on April 16th significantly. It looks like maybe 25% of new cases. And I don't know if that's correct, it shows this. So I'm encouraged by that just because of the meeting that you guys had Wednesday night. It might have put some people to say, hey, we just need to do a better job of what we're already doing. That part will lead to the next thing. But the one chart too, it's 30 days old. I mean, it's March 18th when we have the one graph on there that says, what is 35% social distancing? And I know this is a really fluid thing we're going through, but that's 30 days old. So we're using 30-day-old information. And I agree with the other couple of people because where's the charts and graphs that are talking about, you know, the employees that are being sent home that are in depressed situations and turning to alcohol and drugs and all kinds of really, really bad things that can't pay their bills? We're not using those charts. I don't know why, unless there's an agenda that we have. And Paul, you said earlier that already, without doing what has been discussed Wednesday, that the hospitals, quote, feel like they can meet with our current model demand, which is what we're doing now, that we can already, they feel like they can meet it. So I don't want to get too far ahead of myself into the next discussion, but that's the stuff that I just had questions about the data. I don't know if we need to answer or not, but I just like more data and more current data.
Okay.
Thanks.
Thank you.
Good afternoon. I look at this data and compare it to...
State your name, please.
Troy Jones, I'm sorry. I'm in business. All my businesses are essential businesses, so all of your rules do not affect my business. It's an issue of what's best for the city. All of these models, I like the fact that where they started. They do start from some epidemiological baselines, and they're right with regards to whether you have a 10 confirmed case, total cases that are out there, what is out there. Now, and then you project out. But then you adjust all your formulas based upon what you know that is actually occurring in the area. And I'm not seeing anything there. And if I take all these extrapolations after just one look at them, these mirror very close to New York in some ways, and some ways they don't. For instance, they have 450,000 tests or something like that, and about half of them came in. They have a 2-to-1 ratio between tests and confirmed. We've got a lot different ratio. Those things do impact out there because when we have a 10-to-1 ratio, that means we do not have as many random out there. It gives you an indication of you can't project out to be like New York. New York, when they ran into their hospital problem, they had 31,000, or got to their max, and then it declined. They got to 31,000 hospitalizations. On a per capita basis for New York City, for Sioux Falls, that would be 1,000. So, and then when you do the 10 days, they're in the hospital for 10 days or whatever, your number at about 700 is pretty darn close. So for those numbers to be what we're going to hit, we have to have a experience just like New York had. What's different about New York? You adjust them for what's different. New York, 77% of their people go to work in public transportation. They're touching everybody all the way to work. They live in multifamily housing. We have 95% drive to work. We do not live in the same kind of housing. So we do not have the day-to-day contact to repeat like New York with regards to the spread to what these numbers would say, and maybe we'll find that out. They have 2.5 million people infected in New York. That's comparable to us getting 77,000 in the same time frame. But we don't have the environment they have. So the odds of us getting 77,000 means we have to do a lot of things bad. Number two is what really affects our hospitalizations. This is you also have to adjust this off of ubiquitous. The COVID attacks a certain people very harshly, worse than anything else. I went through every other types of infectious diseases, and they don't hit particular profiles, diabetes, obesity, all those things that as high as COVID is. On the flip side is, with regards to these percentages, is that if we were to use the same thing, that means everybody that's healthy is affected a lot less. So you combine those two things here is, if we really want to stop hospitalizations, we put people who are vulnerable in a place where they're not going to run into somebody. And then we do everything we can to accommodate them. And right now they're under an executive order. So I then ask the question is that if they're under executive order, segregated from us, what the rest of us do, how does it affect them? How does it affect those people that will drive our hospital numbers? But we might be getting affected, but it's 1 in 1,000 will present ourselves to a hospital versus 20 to 40% if you're vulnerable. So we'll be getting herd immunity. The sooner we get herd immunity, they can come out of their houses, they can interact with us, and they're not stuck in their homes. If we keep spreading this out, they're segregated from us longer. So you have to manage not to have more deaths, but you manage to get them to live among us as soon as possible. So with that said, we've done a great job here flattening our curve. We might have done such a good job flattening our curve here is that we've already extended it to some point. We may be above the 25%. So my point is we have to be very cautious about whether we want to do more things because it has negative effects. Beyond the economic, it has an effect on when we're going to get back to normal. And so aggression. Now, the other thing is, I don't know, and I missed, and I didn't follow, I'm still processing some other things, what we're going to do for this 35%. The more coercive it is, one of the things that the CDC says with regards to all the coercive actions, they have about a 2-week shelf life. And we've already been pounding on some things on voluntary coercion.
Thanks, Trey. We're at our 5, so.
Okay.
Thank you, sir.
We've been pounding down on some of our coercion, so I'm not sure how much more discipline we have. We have to be very careful about that, because if we do get the spike we don't know about,
Thanks, Trey.
we have the capacity to pound around. Thank you.
Thank you. Anybody else? Okay, counselors, any questions? Counselor Erickson?
Thank you. I do have quite a few questions, so I'll just ask a couple before we move on. And I know that the charts don't have page numbers, so I quickly numbered them because I'll need you to probably pull them up. When we talk about, where am I going? I'm sorry. I apologize. When we're talking about the hospitalizations, it's chart 12, comparison of social distancing scenarios. And we talk about the no social distancing, 25% and 35%. My first statement is that's great. We've got plenty of capacity. Because as the mayor stated when he started is we're not avoiding people from you're all going to get this at some point. So, we know we're going to get it. We just don't want to over inundate the hospital systems. We want to give you the best tools ever to make sure that if I need it or you need it or our brothers and sisters need it, that capacity is there for us. And so based on these numbers, peak hospitalization, 725 is pretty darn good. I mean, that's within our means, isn't it? What am I missing with this chart?
Counselor, with regards to volume, I think your estimate is right on. 725 excuse me, is a volume that the hospitals can currently handle. I mean,
Could you state your name for us, please? Sorry about that.
my name's Jeremy Cowles. I work for Sanford Health. And I think as you go into that, this was the goal of social distancing as a whole. It was never to eliminate disease. The number of people under the blue curve and the number of people in the green curve are the same. It's the same number of sick people. And if you go for the other curve, the orange one that was really, really high, it was still the same number of people. The important part is, can we bring the volume down to a point where the healthcare facilities in town, Sanford and Avera primarily, can do the work that we need to do and keep people as safe as we possibly can. And my estimate is the same as yours. In the work that we've already done, with the current 25% we're already at, we can get to 700-ish inpatients for those two hospitals, and we can make that work. We can make that work with our existing business of heart attacks, strokes, deliveries, those sorts of things.
Right. I mean, I think that's really positive. I mean, because we don't want you to be over inundated, and so it's clearly showing what we're doing is working. It's clearly showing that the 25% reduction in social contact is working. The other thing that I'm going to just make a comment on too, on page 18, I don't know, slide 18, what is 35% social distancing is the chart. I don't know if Tom can flip to that or if somebody can flip to that just so you see what I'm seeing. It says the school closings restrict to less than 10 persons, and then the 65% on that. The thing that I don't think it takes into account, and I'll ask Eileen if she wants to comment on that, is this is plus all non-essential employees stay at home. So that's really that really heavy-handed stay-at-home order, okay? If we're making everybody stay at home. But what it doesn't take into account is I could name you at least 30 businesses currently that are non-essential that have chosen to close. So that may be, in fact, that 65, but we've got to close that gap that while we're at 25%, the goal is to get to 35, we might, in fact, be more at that 32% because I have at least 10 hair salons that I know are physically closed. The nail place I go to is closed. Many of the gyms are closed, minus one in particular has chosen to stay open. I won't name names of businesses, but also many restaurants have chosen this time to close down and do some remodeling that they thought was, hey, now's the time to do it. I'm going to keep my employees on board, and we're going to redo the floors and paint the walls and do whatever we want to do. And so if you take all those businesses into effect, I'm not buying this chart because the chart is okay if that were in fact all non-essential, but we've got to close that gap between the two of all those businesses that have voluntarily closed. We're over 25%. Let's be clear in that social distancing, and the goal of 35 is a little different in my opinion because of all those that have already closed. And that's the issue I have with this potential chart and some of the data presented. I'll reserve the other questions for now.
Any other counselors have questions? Anybody on the phone? Okay. Councilor Neitzer?
I guess did you want to speak to this last item?
Let's speak if we could, yeah.
Oh, I'm sorry, come on up.
Dr. Pazel with Avera Health. So I wanted to respond to a couple of those questions asked earlier. So first off, thank you. We were involved in the process of presenting these numbers, and we used several of our PhD epidemiologists and stuff when we were coming up with these numbers. And to the point of, do we think that these are extreme numbers? Where do we feel that these estimates are? These are pretty much a midpoint number between high numbers and low numbers, so they're kind of middle numbers. And in fact, what we're seeing, to the point of, the effect of how many you're testing and stuff, how that affects the numbers. The one thing that is very objective in these numbers is the number of hospitalizations, because that's something that doesn't depend on the amount of tests you're doing. If people are sick enough to be hospitalized, they're sick enough to be hospitalized. And so that's the most objective evidence that we have on which one of these curves are we going to be following over time. And so that's the one that has the most effect on these projections. And I can tell you right now from a Avera's standpoint, on our half, we're essentially half of the volume within Sioux Falls. We are exactly tracking our hospitalizations, are tracking these charts pretty much exactly, give or take a couple hospitalizations from day to day. It's been pretty remarkable how much they're tracking. And so I do believe in those numbers. And so I also agree with Dr. Caldwell's when he says At the 25% curve, it does, I will argue with you, we seem to be on the 25% curve right now. That's where our hospitalizations are tracking. And at that, do we have a plan in place that we can manage the capacity, the 750, 800 hospitalizations, the 150 ICU beds? Do we have that many ICU beds in place now on that 25% curve? Yes. However, is that well beyond anything we have ever done in this city as far as managing people? Well beyond any number of ICU patients we've cared for in this city before. Do we have a plan to try to cover that many? Yes. Are we comfortable with that? Especially at the same time, we're likely to be losing 20, 30% of our hospital staff to the illness itself. That's a difficult statement to make. And so that is why, the 35% numbers, we will take any and all help we can get. Because do we have a plan? Yes. Is it well beyond anything we've done before? Yes.
Thank you.
Do you have a comment as well?
So one of the things I think I want to point out, and don't get me wrong, I am more optimistic today than I was a few days ago because of this work that's been done. But I think it's really important when we start talking about the number of people that will be infected in the hospital, we're talking about only what we've calculated for Minnehaha and Lincoln County. You have to remember there's going to be a surge beginning in the rest of the state when we're hitting our peak. Okay? And so many of those people will be coming to Avera and Sanford health systems and other health systems, the VA, et cetera, in our community. And so you have to keep that in mind. Our job is to think about our area, but we also are going to be impacted by outside of Minnehaha and Lincoln County. So please don't misunderstand when we say, and I don't disagree with anything that's been said thus far, but I just wanted to make sure and point that out. So.
And that's something, if I can just follow up with that, that's something that Director Franken and I have talked about in great length, where I said, what about all the people that are going to come here? Because we've already seen people flown in to the hospital systems here from other communities. And we'll continue to do that because we have phenomenal healthcare systems here, and we should be taking care of those, but we also want to make sure that we're mindful of that. And so as the curve here in Sioux Falls peaks before the rest of the state, that might not be a bad thing either, because we can try to take care of our surge before the others. And it's such a weird statement to make, to say, and it sounds super insensitive to say, we're hoping that the death rate is little as possible, because we know you're all going to get it. We're not able to prevent people from getting it. We want to slow it and prevent those from really getting it all too fast. We want you to get it all nice and slow, which sounds crazy to think that that's something that we're talking about at this time.
Somebody skip to what I believe is the last. Sorry, my name is Jeremy Cowles again.
Peak infection one. Slide 19.
Keep going. Keep going. There it was. Back to. Back to. One more. Sorry, another one. That's the one right there. Sorry, this one is one that I included that I'm not sure that I wasn't sure we were going to need. This is a model for the state of South Dakota. We've obviously been in conversations all over the state and all over several states in Sanford as well. And I wanted to bring this one up particularly because it makes a prediction for bed needs throughout the state. And what you see in this particularly is that there is two humps on this. Part of Sioux Falls going earlier in this curve is the fact that we actually do a little bit of getting out of the rest of the state's way in making our peak before the rest of the state peaks. We actually believe that may be a bit of a help to us in taking care of the state as a whole. We believe that by running through some of the illness that we can get and get the people of Sioux Falls back to healthy sooner, we may have a better chance to treat the other people from the other parts of the state that have to come into us later, because the rest of the state is lagging behind this curve. Forgive the rest of the busyness on this slide, What this is a computer model that's been run 50 to 100 times, plotting the possible illness every single time. The dark blue line there is the middle of that curve. The lighter dark blue line that's sort of below that is a lesser estimate that's probably closer. And all of the gray lines are the computer simulations as they run through. I didn't include a bunch of plots like this because they tend to get a little busy. Other questions regarding the state involvement with the rest of us?
Mr. Mayor, do you have something to add?
I did, not for Jeremy, but Eileen, can you go to the slide right before this? You didn't show, but you had it ready in the can. That shows that gray band of that capacity, this one. This is one you didn't show yet. I wasn't sure if this was something we were going to show or not, but this band on the screen, this shows the bed capacity or the capacity of the two systems right now based on where we're trending. And this is data that we've now seen in the last 2 or 3 days that's driving some of the decision making. So you can see right now, if we don't do anything else, if we don't put in any new ordinances, if we don't employ any new tactics, we're knocking on the ceiling of complete capacity. Okay? And as Dr. Basil said, it's like, do we have the capacity? Yes. Is it unprecedented, like probably nothing we've ever had to do? Yes. So the question we have in the following, and per my opening statement, was, does a stay-at-home order move that down? And it would, but at what expense? And are there other now strategies, now that we know that we're knocking on the ceiling of that band of capacity, are there other things that we could do that would still help free up a buffer and some capacity to give them a little more confidence and breathing room without a stay-at-home order or something that many people feel is too restrictive? So I want to be clear on that's why the situation is so fluid, the data is so fluid. This is what we've been looking at the last couple of days to say, okay, we think there's maybe a win in here somewhere in the middle. That still puts public health and public safety and lives number one, but also takes into account all the other factors, the ancillary factors and the unintended consequences of a stay-at-home. So I think this is an important slide to look at.
Okay. Councilor Neitzer, and then Councilor Kiley, you'll be after that.
Could somebody help me with the hospital bed issue? And first of all, I understand that, it really comes down to how you define a bed, because obviously some maybe have certain equipment, some may not. Of course, you have to have the staff to take care of the patients in the bed. But I've heard a number of numbers, and I'm hearing another new one today. The first was, I thought we had something like 545 or so beds at both hospitals certified, and that now we've increased to, by clearing things out, because we literally have workers, I think, being furloughed and nurses sitting at home doing nothing, and we have like 800 beds now between the two. And I've also heard maybe we're making changes so we could go up to 1,000 not between the two, but each. So, and then I'm hearing the 700 total. That would be 350 between the health systems. So somebody help me with all of these numbers. Where are we getting this? We only have 700, and are you taking into account all of these things you're doing to add capacity in expectation of this surge?
So Mike Wilde from Sanford Health, and I hopefully can sum up everything that was just put out there. We are, speaking for Sanford, we're licensed for 545 beds, which is our usual publicly reported licensed beds, and there's regulation within that we have to report. We are always planning on surge. That's part of our obligation as a healthcare provider. And we can surge to the point of our physical space in addition to our staff. So where we're at Sanford is we anticipate the ability to provide care in the moment for far more than 545 people. And what you see the numbers there are the numbers of COVID admitted patients, but as Dr. Cowles alluded to, there's also just our regular ill patients that we're currently caring for on top of that. And this past 30 days has given us a pretty good number where we're going to be at from that standpoint. So working with our facilities, both in and outside of South Dakota, or what we call our network facilities, and transferring between that and the surge within the hospital here in Sioux Falls, we do feel we can meet these numbers, but we're close. And in terms of our staff has actually been, we have not furloughed or anything of that nature. We still have our staff. Some of them are certainly not doing what they once did, for instance, screening and things like that, but we have a lot of staff that while they may be a nurse in a clinic, they're learning how to be a nurse in a hospital right now as well. And so we're doing what we call cross-training with a lot of our staff in preparation as well.
Okay. What percentage of admitted inpatient COVID patients are likely to go on a respirator?
I don't want to be different than the data that was presented, because I think that was up there. If I
Was it?
remember right.
Was it on there? Yeah, if you could. And then do we foresee that we have the capacity? Do we have the respirators we think that we're going to need?
Yes.
Do we have them now?
Yes.
Okay. Mike?
Did you have a comment on that?
I think he might have if we could maybe let him comment as well.
So the answer to the question of what percent, it's usually pretty standard between 25 to 30% of patients hospitalized are going to need the ICU, and 75% of those will need the ventilator. And so the numbers that are out there, do we physically have that many vents within our two systems to hit that number? Absolutely, that answer is yes. Is that number well beyond any that we care for on an ongoing basis? The answer to that is also yes. So,
okay.
Same sort of thing. Do we have cross-training going on so that we can handle, multiples of these numbers so that no matter what comes in, are we preparing to meet that number? Yes. But is that going to be at all comfortable for us or anything any of us has actually done? No.
Okay. Maybe the next question I have is, I'll call it maybe one of the biggest questions I have is, I'm finding a bit of a disconnect because I continue to hear the governor and the Secretary of Health, including the governor this morning, talking very confidently that we have the capacity, we're doing good, we have all the beds we need, and then locally I'm hearing we don't. Can somebody please square that for me? Especially when you say that the state is working on these numbers. I'm hearing, we're saying that we have to keep pushing and we need more, and they're saying we don't.
I think the state is going off of what we gave them as our maximum capacity numbers. And according to our maximum capacity numbers, we can accommodate that curve. I think what you've heard from both of us is that those maximum capacity numbers would be unprecedented. They would be something we've not put into our hospitals before. Can we plan for it, train for it, get ready for it? Absolutely. Is it something that we did yesterday? Absolutely not. And so the question of can we do it, we believe the answer is absolutely yes. The same question has to be asked of my friends across town, because both answers have to be yes if we're going to be able to pull this off. But at the same token, the governor asks us if we can accommodate that sort of thing, and we start working and training and moving forward to say, when people come, we will have the ventilators available, we will have the beds available, and we will have the people available to pull it off if we need to.
Okay, that's fair. I struggle both ways between, I'm always skeptical of models, so one of the questions I would have for somebody to answer is, what is your confidence percentage, perhaps, that you think you're going to hit this, versus us going through this and we only hit 50%. I mean, it's a projection, but we are being asked to hollow out our city and our economy for a projection, and so I'm looking for some confidence level.
So we have a phrase that we use, tongue-in-cheek, called the best of the worst. And that is the curves that we run off of. What's our best estimate of what the worst case scenario is? And I will tell you that we then take that number, compare it to the city's number, compare it to Avera's number, and see how close we get to. And we're close enough that we felt like the presentation in front of didn't need my presentation and Avera's presentation to compare numbers that were within 50 of each other. But that being said, we feel that that is the numbers of the worst case scenario that we have to prepare for. Do I think we're going to come in low of that? I certainly hope so. I don't hope so because of the hospital. I hope so because of the sick people. I hope so because there's 5 people in my family, and if COVID hits somewhere between 20 and 80% of the people in the country, because that's the error bar that people are giving us right now, 20% is one of my kids. 80% is everybody except my wife. She's the toughest one. Christine laughs, she knows my wife. But that's the uncertainty we're dealing with when we're dealing with numbers like this. But if you compare New York and you compare the data there, and you compare the data in Washington State, and you compare the data in California, where social distancing appears to be working fairly well, and you use Italy and China, we can say with some confidence that these new, the current progress that's currently up on the screen is a fairly accurate estimate to what we expect to have, and we don't expect to go over it.
Okay, I just, you're telling me that based on the worst case scenario, which may not come to pass, that we should continue to lock down the city. And I'm not saying that to you just personally, that's what I just continue to struggle with. So.
And I understand that. We continue to struggle with that as a health system because all of our partners right now that are out there are trying to do their regular business, and it's being hindered. And we struggle with that personally in my house and my neighborhood, and I totally get it. But I can tell you the instant we take our foot off the brake here and we let everybody go back, that curve looks a whole lot more like the one on the left than it does like the one on the right, and we lose the ability to handle the capacity again.
And I'm certainly not even suggesting that we let off the gas. I was just thinking about the status quo. I've only been.
Can I speak to that though, Greg? 'Cause
Yeah, please.
I don't want to, I know Jeremy's on the hot seat with the question, and
Yeah,
I'll be the candid guy, because I'm having the conversations with our executives and so forth, and that is, Sanford is confident that a stay-at-home order is not needed. They've expressed that to me. Their leadership has, their physicians have. Avera has said it certainly wouldn't hurt at this point. And we will endorse that. Sanford has not endorsed that. So there's even differences of philosophies and opinions on that. I will say that based on this new data, however, and I don't mean to speak for Dr. Basil or Dr. Elliott, but even in some communications I've had with Sanford execs, or Avera execs the last couple days, and what you're seeing on the screen, I think there's a confidence level that what we have been doing is working, and now with this new data, a stay-at-home order would take us down quite a ways. There's things we could do that wouldn't be as drastic, that would give us a little bit more of a buffer, so that we're not in such unprecedented times with the capacity. And that's what we're going to talk about in our next item. But I know what you're asking of him, and I don't want to put him on the spot, so I'll be the guy that shares just the cigars, smoke-filled room discussions that are being had right now and trying to figure this out with all the leadership.
Okay. In a healthcare system, there better not be smoke-filled rooms.
Well,
Yeah. No, and and thank you very much. I would just finish by saying, I've been on this earth for 41 years, and almost by and large, models have almost very rarely come to pass. So I'm going to look at the data, but I'm always a little leery of trusting projections, because many times they come in not even close to what the worst case was. So,
if it helps any, my chief operating officer at Sanford is getting really tired of me being right about the number of ICU patients for the last 4 days in a row. We're getting fairly good at this model at predicting the hospitalized patients. The part that we haven't seen yet, and you're absolutely right, is the number of the number of people in the ICU. What we haven't seen yet is the biggest surge in the hospitalized patients, and I hope we don't. But the things where we really have to be careful about is the resources that it takes to take care of an ICU patient. And those are the things that are most vital to us.
Thank you.
Let's go to Counselor Kiley.
Thank you very much. Counselor Neitzer just asked majority of my questions, and they centered on personnel.
We're losing you a little bit, Counselor, if you can talk closer to something.
Sorry, I'm as close to my computer as I care to get. Can you hear?
That was better.
My question centered on beds versus personnel versus ventilators, and I think Greg asked that question. For the most part, it was answered. However, I do say that I would have a little, I'm sure the doctors probably wouldn't want to say this, but I will. If I were a patient and I had now a nurse or personnel treating me or caring for me that has just been cross-trained in the last few days versus personnel that's been doing this job for 10, 15, 20 years, I'd have a little bit of concern. But I guess it is what it is, and I do appreciate the fact that they are preparing for that. So there is that to consider when you are cross-training personnel. And I think my other question was answered during the presentation of the modeling, that the models do reflect the numbers up through today. Because I do know in the last 2 days, we have, while we're seeing the increases daily, we're starting to see that the increases are dropping over the last 2 days. Wednesday of this week, we had an increase. And when I'm talking increases, I'm talking just Minnehaha and Lincoln County right now. On Wednesday, we had an increase in infections of 176. Today, that increase was 98 for both counties. I hope over the course of the next several days that we continue to see that type of decrease. But I just wish to confirm once again that those numbers were factored into the modeling we just saw today.
Counselor, can you ask that question again? And then I'm also going to,
Take your mask off, Jill, so we can hear you better. There you go. Sorry.
Might need you to repeat that question again, Counselor Kiley, but I also want to offer that Dr. Amy Elliott, who's a doctorate in epidemiology, who's on the call with Avera, and so I wouldn't mind her sharing some thoughts as well and give her the opportunity to do that. But at first, if you could repeat the question, and then whoever.
Okay, and you were kind of fading in and out a little bit there. And sorry, I'm on a computer, so I can't see speakers coming forward to the mic. I'm still looking at a current progress graph on my computer. The numbers have the increases that we've seen over the last 2 days. Well, we're seeing increases, but it's dropping. It was 176 additional infections for Minnehaha and Lincoln County on Wednesday. Today we had 98 new infections, so still an increase. Today it was an increase of 98. I just want to make sure that that is reflected in the modeling that we saw today. This tapering of the number of increases on a daily basis.
This is Mike Wilde from Sanford. No, the last 2 days are not reflected in the modeling. And if I could just make a comment that you had made in regard to your cross-training comment. The cross-training we're doing is nurse to nurse, and it's just really a matter of technology with an IV pump versus a clinic setting and things of that nature. So, we all start new jobs and we're all vulnerable at those times, and we all learn and improve or maybe not improve as we go through jobs. But The reality is we're doing it in as safe a manner as possible.
Understood.
Any other questions, or were we waiting for somebody else to answer? I'm sorry.
I don't have any other questions, so if Jill wants to continue.
I guess I just wanted Dr. Amy Elliott a chance to make a couple comments just about the confidence levels of the data, if you wanted to, Amy.
Sure. Hi, this is Amy Elliott. Can you hear me okay?
Yes.
Well, good. Thank you. So many good comments that have been said today, and just something I'd like to orient people to in general with these models. I think Mayor Tenhaken said this very well, that in 6 months they'll be exactly right. And so what is put forth in front of you is really information based on what we already know from the hospitalizations, things that have occurred thus far, as well as what we've seen happen in other areas of the country, and trying to combine those informations to project out to help with planning efforts. Now, these models are also supposed to be extremely fluid to
You're fading just a little bit. I don't know if you can get a little closer to wherever you're speaking. Sorry.
Okay, no problem.
There you go.
These models are meant to be very fluid in that, changes in social distancing, for example, can really help improve that. And the way that these are best used is if you really monitor and keep putting in very real data. I like the gentleman who just spoke. I think maybe we would want to hire him as a researcher within the health systems. That you want to be able to track where things are at, and that will change the nature of the curve. Where we're at right now in this is, you can see if you draw a little line up around April 17th, and by the way, these are tracking right now. The 25% reduction is tracking with what we see in the hospitals. But as you see in that curve, we're in a little bit of a sweet spot right now. Okay? And this is an opportunity where changes in social distancing and also making sure that we maintain current, for sure, can be done now. If you go out to, let's say May 11th, for example, okay, you can see we're getting really close to the peak of that curve. Social distancing measures would have less of an impact then on helping us control that peak. And so what we're in now, while there's a frustration for lack of data that we're currently experiencing because we haven't had as many hospitalizations and things like that of other parts of the country, and we are projecting here, what we are in is this sweet spot here where we have to look at what changes could we potentially make. There is a confidence interval around it. Dr. Basil mentioned that we look at worst case scenarios and we look at best case scenarios, and then we figure out what's a realistic plan. What's put before you is a realistic plan that all of the health systems in the city have agreed on as being really a good planning strategy. But again, this needs to be monitored throughout to see if that strategy needs to change. So I hope that's helpful.
Thank you. Councilor Staley.
Well, first of all, Mr. Mayor, I really appreciate your comments when you first opened the meeting about public health, public safety, and you stated that's your greatest concern, and it absolutely is our greatest concern on the council as well. And you put out the call last week to encourage citizens to reach out to us at one of your press conferences, and they have. I mean, this has been a high volume, high intensity communication with constituents through emails and phone calls, personal contacts. So I know we've all been listening. We've all heard your concerns. And on either side, for my part of it, I'm hearing about 50-50 of people who want us to do more, and then people who are saying we've done enough and we need to make sure we're protecting the business interests. When it comes to the tracking of groups, I do want to say that our numbers, and of course there's a lag of infection versus hospitalization, but the last few days have been cold. People aren't outside. And so I'm going to predict that coming up this next beautiful week, I shared that wonderful forecast on Facebook that we were seeing, 7-day, we're going to see some numbers increasing. And one of the concerns I'm hearing from people is that we've got big groups of individuals gathering, and there's nothing really in place publicly to address that. So I don't think we can let up and say everything's flattening out or within the control level. A few questions. Back to that, we've got 40 in the hospital, and we've got over, 1,400 cases here in our counties. 40 in the hospital. So how many people, and maybe one of the medical professionals can come up, but does that mean, how many people right now are infected? Okay. So, I mean, 1,000 verify, or what, 1,100, 1,400?
Today we have, in between Minnehaha and Lincoln County, 1,234 cases.
And of those, 40 are sick enough to be in the hospital?
That I would not know absolutely.
We had,
is that correct, 40?
I thought on one of those graphs we saw 40. 40, yes. So, so that's 1,000 people who have been tested, and they're apparently healthy. Of those, what do we got? Of 1,000, 1,200 are diagnosed. Only 40 of them are sick enough to be in the hospital. So the rest of them are at home, shelter, isolating themselves, or what? Right? They're not supposed to be out. But how many other probable people are there? Are there 10,000 right now in the community? We had the one guy got up with the. How many do we think? How many people are currently infected?
So the difficulty with that question, it gets back into A, our ability to test for this virus, and B, the number of people that may be asymptomatic or have extremely minimal symptoms from the virus. Papers out of places from all the way from Wuhan, China to Harvard would estimate that the asymptomatic rate for this virus is somewhere between 20% of the population and 80% of the population, which gives you a range in South Dakota between 700,000 people and 200,000 people at the end of the outbreak. So to give you a square answer is to not give you a square answer on how many are infected today. So I apologize, but I can't give you a solid number on what that might be.
So we're really kind of, as far as, I'm so grateful to have this time right now, because I think the public is in the panic mode, partially because they're concerned about their businesses going under, but partially because people are concerned about the, catching the disease. So having this information about, to tell the people, hey, you've done a great job. The social distancing thing has worked. We need you to do a little bit more, I think is going to be comforting to people, because they weren't sure some people are feeling like a tidal wave's going to be crashing down on our community. And it's sounding like that's not the case.
No, I think you said it perfectly. People have done a very nice job of socially isolating up until this point. And if healthcare had an ask, it would be continue social distancing, continue to wash your hands, and continue to be home as much as you possibly can for the foreseeable future. And I'm not going to put a week or a number of months on that yet, but the work we're doing right now is doing the job we asked it to do.
Well, and what the terminology, I'm going to use that word essential. It just came up to me yesterday, but we were having the conversation about whether your business is essential, and it came to me yesterday. Let's turn that around, and let's say to our citizens, don't go out unless it's essential. I think our citizens really value their own independence, and to say, and their constitutional rights, but to say, think about when you go out, make sure it's an essential trip. And the other thing that our city attorney brought up, I'm going to always give this back to you, Stacy, but that our citizens are essential. That word can have so many different applications. One thing I had heard is that, and I don't mean to be morose here, but of the people who go on ventilators, 50% of them will not make it.
I think that estimate is probably a little overblown. The number of people on ventilators right now in U.S. healthcare can't be truly estimated for the number of people that come off healthy, and it's extremely variable according to age. And so right now, we can't calculate that number for New York because there's still thousands of people on ventilators. So until we know how many of them come off ventilators, I can't tell you how survivable it is.
But we can say to the public, you don't want to get to the point of having to go on a ventilator.
Certainly.
That's pretty darn serious when you get there.
Absolutely. Right. It's always been very serious.
Well, it was brought up by Mr. Jones that the people who are impacted by this, and of course we've heard this before, but that if you've got a jeopardized immunization system, that you're more at risk. But I've also heard people say, and then there's also if you're over 65, apparently you're more at risk. But I'm also hearing, and our Dr. Tingley said this at the Board of Health meeting last week, but that this thing tends to affect everybody.
It tends to affect everybody. The fatality rate is different according to age. And so what I mean is there will be a number of 20 to 40-year-olds who are very symptomatic and need to be hospitalized. And that number is, in data from New York, is about 20% of the cases that end up in the hospital. And the number of 80-year-olds that end up in the hospital is about 20% of the people in that hospital at that time. This was 2 weeks ago. But the number of 80-year-olds that walk out of that hospital is very different than the number of 20-year-olds that walk out of that hospital. Does that make sense?
So you're talking about success, recovery rate.
Recovery rate.
But how about just the amount of people who get to the point, the percentage of healthy people who have to be hospitalized versus the compromised?
The compromised people are hospitalized at a much higher rate. The question is what compromised means, and we're learning that as we go. We can say that diabetics get hospitalized more than non-diabetics. We can say that people with heart disease get hospitalized more than people without heart disease. We can say people that are overweight, particularly excessively overweight, get hospitalized more than people who are not. And we're learning those things as we go to try to predict who the people are that we need to protect the most.
But and here's the balance, is that then do we say to a certain group, well, you're not in that risk factor, so you can move about freely, you can do all of your activities as if this wasn't happening, and then we'll just take care of, put these other people over here. That really isn't something you're proposing that we do.
Interestingly enough, Sweden tried it. And if you'd like to Google Sweden's death toll right now, they're currently leading the globe. They took all of the older folks and put them effectively shelter in place, and they told the younger population they could move around freely. And right now, Sweden is one of the places where you can't get a ventilator. It's the only place that's done the experiment that way. If you want to call it an experiment, it's kind of a poor word to use in this situation. But they did make that, they did try that there.
Thank you. And one more thing to address is that our state epidemiologist said last week that we are concerned with reinfection. So the question is, how does because if someone can have it, they get past it, and they can get it again. How is that going to impact us? Because we're doing the surge, and is there a chance that we do the surge and then we have another surge that we don't really know?
Right, we don't really know. We don't think so. But much like influenza, some viruses you get once, like chickenpox, and there's a good chance you don't get it again. Some things are like influenza. The virus mutates a little bit every year, and you could get influenza a couple of years in a row or a couple of times in several years, which is why we develop immunizations for those. Obviously, the goal is to develop an immunization to this as well, but at this point, we don't know if there's a reinfection rate or if that's due to them seeing two different types of the virus. There are currently 10 of them noted in the CDC's bank of information that are slightly different from one another that all count as COVID-19.
Okay, thank you. And did you have something to add?
Dr. Basil, will you come up too? You guys, feel free to come nice and close and put the mics up. I know they're having a little hard time on the feed, so keep them right there, come close, and thank you.
Alice and I are a little bit taller. We'll raise the mics. That'll probably help too. Yeah, Dave Basil with Avera again. So from our experience, what we've been seeing so far, of the ICU admits and the hospitalizations both, because they're tracking about the same number, about a third are people that most of us would agree would people you'd expect from influenza seasons. You know, they're 70s, 80s, and multiple medical conditions. Another third have, for something about this virus seems that hypertensives and diabetics especially seem to be at risk of it. And so I would call middle-aged hypertensives and diabetics that normally you wouldn't consider to be that much at risk. We're seeing a large population of those that are coming into the hospital. And then the other third are indeed, we're seeing 20-year-olds, 30-year-olds come in that no past medical history that have that. Now, I think you're also right in that, the ones that end up intubated do tend to be the ones that are at those higher age limits. And you're also right that you absolutely don't want to be in that population of patients. One of the biggest problems with this virus overall is the length of time that people stay ill. Influenza even, the average length of stay in our hospitals are about 3.5 days. Average length of stay for these people is somewhere around 10 or 11 days. And that's the average because a lot of people die before that. If you're going to get ICU sick and recover from this, it's a 2 or 3 week process before we can get you out of there. I don't think I can think of a patient yet. My wife is a pulmonary and critical care physician. I don't think I can think of a patient yet that we've been able to discharge who was intubated yet. We've taken, a patient or two off the vent, but they're still recovering. That's that long of a thing. So you're absolutely right there.
And with the hypertension, is that like just people being treated for high blood pressure, or just the average citizen or are we talking about someone who's battling with it are we saying anyone on high blood pressure medication is more susceptible?
It is. That's definitely one of the CDC criteria is that has said they're more susceptible, that hypertensives are a known susceptible population for whatever reason, and diabetics as well.
Any other counselors? Counselor Starr.
Thank you, Mr. Chair. I think Dr. Elliott in her comments calling in from home, I think she was offering Counselor Kiley a job more than she was anyone in the room is how we did it. I think she missed who was at the thing. So not to speak for her, but I think that was where she was headed. Yeah, I'm thinking you're probably pretty busy already, Dr. Wilde, by the time we're done. So I want to go to that chart 11 that we looked at. This current progress is a good one, but we talked earlier in the presentation when we were looking at the numbers and the phrase quality of care came up. And anecdotally, living with an ICU nurse who routinely worked 6 out of 7 days that were supposed to be 12-hour shifts that often turned into 14 to 16 hours, that to see that person after that 6 shifts, the quality of care, I know the quality of care I received on day 7 wasn't as good as probably it would, but it took that week to recover. So my concern in the difference between the 25% social distancing and looking at 35% social distancing, the human factor. You guys, and I throw this out this way, but you guys can model this all you want, but it's very difficult, I would assume, to model in the human factor for the allied health workers, whether it's the nurse, it's the surgical techs, it's the respiratory, it's the physicians as well. And if we get to the point where we're having 700 plus or 750 inpatient beds, the human toll, we've spent a lot of time in the last few days talking about the economic impact, but the human toll that it's going to take on healthcare workers not only the infection rates, but just the physical demands of gowning. I'm almost out of breath in the little bit wearing the mask today by the time we're done, let alone putting on full PPE. Or someone offered me an N95 mask a little bit ago, and I'm like, I couldn't get it to seal anyway. And the testing that it takes to get that to seal, to do the job that it would do, that the paper mask is probably gonna do me just as much good. So really, what I'm trying to, I guess I'm making as much of this statement, but the difference between 25 and 30, the difference between 750 beds that we think we can do and that you can assure us, talk to me how much easier it'd be at 325.
When you get down to those lower numbers, we're getting up into closer to what our, our high peak average running capability is. We're getting down to where things are closer to, hey, this is something we're used to. We're used to handling these numbers. Are they still heavy? Are they still going to stretch us? Are we still going to worry about supply chain things, PPE, how many masks, how many gowns and stuff? We're still going to be worrying about that. But you're exactly right. We're not putting people in uncomfortable situations. We're not putting people in things that they maybe haven't done for 5 or 10 years. And then there is that emotional. As I talk to residency mates that are in other cities and stuff, they say that's one of the biggest things is that, you start getting worn down after a while of this, and it's the emotional toll as much as the physical toll. But it is also, it takes so much longer to care for these patients, putting on the gowns and the gloves and then taking the hoods and everything back off, going in and out of rooms. It does take more time to care for them.
Thank you. One of the other things, and I'm not sure that, Dr. Basil, you're the right one to answer this, but talk to me about testing, because that's really the basis of this model. We're still short of testing. We're still rationing the amount of tests. You almost have to be presumed to have it or have showing symptoms before we're testing, and we're still asking people to wait in lines for a considerable amount of time. So if you're already sick or you're elderly and you're sitting in a car for hours as things warm up, hopefully over the next time, but not having the bathroom facilities while you wait in line for a couple of hours, or being able to separate those. So where are we at with testing? Are we testing enough to make the model be as accurate as possible?
So actually, that's one of the nice things about this model is this model is driven by hospitalizations, not number of tests. And so the degree that you're testing within a population doesn't affect these numbers. It's the number of hospitalizations we're seeing is what this is based off and what the projections are based off of. And so that's one, going back to your question, well, we've had a couple days here where we've got fewer cases. Yes, but actually the number of hospitalizations we've had are actually going up at a pretty steady incline. And so it's more the number of hospitalizations. That's the objective finding, because I could shut down the number of cases in the city tomorrow just by cutting down the number of tests that I do, but I can't shut down the number of hospitalizations, and that's what drives the modeling.
Thank you. And if I could, one more thing for self-preservation when I get home. There is a difference between a clinic nurse and an ICU nurse, so that's more for my self-preservation, so. Thank you.
Covered. Before we go around again, Councilor Brecky or Sale, I believe. Do we have any questions from you? Just checking while you're on the phone.
Councilor Brecky.
Okay.
This is Councilor Brecky.
Go ahead.
Yeah, I really don't have any additional questions, and I really just want to thank my fellow council members. You guys really asked some terrific questions and really fleshed out the presentation that we had in a way that I think has been beneficial, certainly for me and for any other folks that are watching from home. So I don't have any further questions, but I do thank all the council members there for the questions that they asked, because that really covered all the things that I had in my notes that I wanted to ask as well. And I thank all the doctors and staff for your due diligence. And I am a fan of modeling, and I am a fan of these are the kinds of things that give me confidence. So, and this kind of a presentation helps me, proceed with confidence. So I thank everyone for your efforts.
Councilor Erickson.
Thank you. I just have a couple more questions. First, I hate that we say 20 to 80%. It reminds me of the snow forecast in South Dakota most times, where we're going to get 2 inches to 14 inches. It's just a frustrating area to be in with confidence, but also knowing that so many will be asymptomatic that a lot of people may even have had it and not realized And so it's just a unique place to be in. I'm curious a little bit if someone can comment a little bit on, as the positive test increases, so does the daily recovery rate. And if we're tracking the difference with that, because it was almost equal today. It was real darn close to being equal, which in a really crappy situation, we've got to focus on a couple of those little benefits of saying, great, this was a great day. Tomorrow it might really be terrible. We might have 300 more cases, but I'd like somebody to talk through how that data is being tracked as far as recovery rates with the positive rates, and maybe even potentially having some charts with that. And then I'll ask one more question that whomever wants to speak to it. I took a call today from a nurse who was furloughed. And so my questions to the hospital systems, not to put you on the spot, and I feel a little bit bad at asking this question publicly, but I'm hearing that there's several furloughed hospital system employees, many that don't have anything to do because we're gearing up for this and all the elective surgeries that aren't taking place. I do have a couple friends that work in elective surgery areas that are no longer working as well. And so that's a different sector of your hospital systems, but talk a little bit about the furloughed employees, if they can be repurposed into this, or if that's not even an option, because we want people to be safe too. So those two things as far as recovery rates and then the furloughed employees.
I won't answer that question, the second one, but I can talk a little bit about the first question. And when we talk about recovered cases, Counselor, that is something that, we know we see those recovered cases on the state's website, and that's good. And it is, you're exactly right. We have total cases. It's our best measure right now of really being able to see where we're going to trend with the surge, and that's why we're tracking it that way. As has been described already, hospitalization rates and ICU bed capacity and demand are going to be the things that we'll really be working with the health systems to monitor in this next operational period.
Thank you.
So in regard to the HR operations of what we're trying to accomplish, I'm going to take a stab at that, but please understand the role I'm in versus our operations and nursing leaders and things like that. So when I say furlough, unemployed, laid off, those don't mean a heck of a lot to me, so the ins and outs of that I'm going to be weak on. The reality of the situation is we don't have a lot of patients coming in, and we've asked patients not to come in out of the setting of public safety. And we've been regulated to not do elective surgeries, things like that. That's the reality of the situation. So there are people literally that do not have anything to do. We have been trying very hard to repurpose, cross-train, et cetera, without saying that we are going to not have you employed at this facility anymore. And I guess that's kind of the best way I can put that forward. There is anticipation that, as we go through surge, that everyone will have plenty to do. There's anticipation that once this hopefully is over sooner as opposed to later and everyone can safely return to work, that is fine. We'll be back as we were. And while we do that, we are trying to find very unique ways to get people to, whether it's online training that they need to do, accomplish every year that we're mandated to do, things like that. And it's just anything that we can have people doing. Absolutely are trying to do that, but the reality is there's not enough. The reality is that you can imagine the number of employees we have and the revenue coming in right now. It's not lining up for us as a business either, but at the same time, we are committed to the healthcare of this region.
Thank you.
Councilor Neitzer?
I have a couple more questions. The 20 to 80% number, just to remind me, is that the projected number of totally infected when this is done of this virus?
So yeah, you can think of it as the number of projected people that got the disease, or you can think of it as the people who are getting the disease but not having symptoms. Either way works. The way I would describe it is if you had a blood test that could say for sure had it or didn't have it, and we took it, a year from now and ran it through everybody, we're still lost in the number. Somewhere between 20% and 80% of the population would have a positive after that.
Yeah.
Yep.
symptomatic or asymptomatic, if you just tested everybody and saw who had the antibodies or whatever. So does that range, if that range differs, if our 20% are infected versus 80, does that change your modeling? And if so, what number in there did you choose for your model? Does it have anything to do with the...
It absolutely changes our modeling, and it absolutely changes what we use for, the first part of any model like this is what's called the attack rate. And the attack rate is the number of people that get the disease. Now, the attack rate is then divided out into people who had symptoms and people who didn't. And to go further into that bag of weeds would get you a degree in epidemiology that I don't know that you want, but that's the first assumption we use in this modeling. And so I can tell you that I've modeled this everywhere, personally, everywhere from 20% attack rate out to an 80% attack rate with a 20% symptomatic rate. And we've done it all the way in between. And the current data, I think we started with a 50% attack rate, a slightly smaller symptomatic rate.
Okay. And then I guess the part somebody can hopefully help me with, because I didn't quite grasp this. You're talking about the trend line or the number of people that are going to the hospital. The number hospitalized is tracking exactly kind of as you're projecting. I don't know if it was Dr. Basil or somebody said that, but how do we, if we don't know the total number of people infected, how do we, I guess, the hospital.
We're right.
Yeah, exactly. Yeah, that's a piece I'm struggling with. How do you have a confidence that it's tracking exactly like you projected? I'm missing something. So
it turns out you can put in lots of different variables, like I said, and get a curve. And it turns out several of those curves will give you a similar number or a similar curve, depending on the variables you put in. And what we're trying to do is use data from New York's hospitalizations and Italy's hospitalizations and Washington's hospitalizations and do things called regressions to try to find a mathematical formula that accounts for all three of those. You know, how many people got infected, all of those variables that we put in there. And then we put that in to South Dakota. And we say, okay, if that's South Dakota, knowing that we're not going to be able to test perfectly, that we can't do all the tests that we want, what's the next best number we could do that's never going to be that controversial? Well, that's going to be people in a hospital. And so we try to do our predictions on people in a hospital and people on a ventilator, and then see if we can predict those as people come in and get sick. And thankfully enough, our model has been tracking fairly accurately to those numbers.
Okay, and then finally, so when you're looking at other areas of the world and in the country, do you try to make adjustments for for factors such as, because epidemiology has a lot to do with demographics and things like that. So like if you go to Florida and it's a retirement community, maybe your median age is a lot higher than it might be here. The number of people that might have chronic conditions in a particular geography. New York City was brought up. The fact that they're right next to each other all the time versus being spread out in Sioux Falls. Do you try to make corrections for that sort of thing?
Absolutely. On the chart that I showed you with the two humps, the first hump is based on the population of Sioux Falls and how densely populated they are. The real change in that graph for the second hump isn't that we manipulated anything about the virus, it's that we made the people farther apart. So it's slower to spread to the rest of them. So we can model by county and say, okay, the population density of Minnehaha County is this. And so we think it'll spread this fast. The population in Buffalo, South Dakota is not nearly as dense. And so we think this will plot a lot slower in Buffalo than it will here. And so we're able to model both of them at the same time.
Okay, and then if I could, one last that I just thought of, and thank you, this is very helpful. Obviously every hospital has certain things that they can do, and I'm not in the medical field, but, they could do level X trauma, things like that. So there might be certain things that a Sanford might be able to do in Sioux Falls that a small town hospital just doesn't have the ability to do. So do you have any sort of projection, or have you figured out how many people that need hospitalization in the state of South Dakota by a percentage are going to end up at one of our two facilities? Because if you're in a rural town, you're coming here likely.
We've done those projections. I can't give you the numbers off the top of my head, but built into that hospitalization rate is very much a factor of this is the number of people that are going to come to Sioux Falls to get their care. And what we're working on as a model is really the goal of bringing as many people here as we need to, and bringing people back to those smaller hospitals to recover, after they've gotten through the worst of their illness. Now, I can't speak for Avera if they're using the same plan as we are, but I can tell you that that's the way that we're planning to do it. Because I agree with you. The differences, I grew up in a little town in northwest Iowa, and the differences in their ability to handle, incredibly sick patients versus their ability to do it in Sioux Falls are completely different, and we have to be sensitive to that.
Okay, thank you. Very good.
Questions, counselors, before we move on? Counselor Staley?
Just one more. We've been telling people to stay home if they're sick. It doesn't matter. We've been telling people to stay home if they're sick. And I suspect there are people who are staying home who are really sick. Right. And there could be people who have stayed home, gotten really sick, and died. Do we have any way of tracking that?
The state of South Dakota, obviously, anytime there is a death, is notified. And if they were diagnosed and then unfortunately died at home, we will find out what those numbers are. Obviously, whenever we talk to a patient, we go through, you've been diagnosed with COVID. These are your instructions. And whether we diagnose them in one of our clinics or in one of our testing centers, or if we diagnose them and then call them on the phone, we lay out criteria for them, just like we would with any other illness, to say, these are the important things that you need to call us back for. These are the important things you need to call an ambulance for. And we make sure that they're aware of them as well as we are, because obviously our goal isn't to prevent people from getting to the hospital. Our goal is to make sure the right people get to the hospital.
Right, but if someone were to die at home and there would be, you aren't doing active testing on the deceased people, right? I mean, if especially like an elderly person who maybe who got sick and just didn't have anyone else around, the cause of death, I mean, unless you did an autopsy, and we aren't really tracking that.
That's tracked by the state of South Dakota.
Of the cause of death.
Right.
Counselor Starr?
Mr. Chair, I guess more for Director Franken, if I could. One of the things that out of all the calls and letters or emails that I've received over the last couple of days have been pretty consistent is, did we add an economic part of this to the modeling? And what I didn't get, what wasn't consistent in my emails that I got from people, there was a lot of calls for what's the economic impact to my business, but there wasn't a lot of economic data talking about if I spend 10 days in the ICU intubated and then the time that it takes to come off, and balancing those two things. So is there an economic component to where we're doing? Do we have an economist on board? Are we doing finance with this? Or how do we how do we balance that cost to business with the balance of loss of life as well as the loss of productivity and loss of workforce? And I'm thinking I'm getting deeper than where you're going with public health. So, but I got to ask, or I got to start somewhere.
I think you're asking really good questions, and that is the balancing challenge, right? Is there's the pretty straightforward economics of when businesses are not seeing customers come into their businesses, or when they have to, shutter their doors because of reasons of, stopping the spread of COVID or whatever the case may be. or when they finally feel compelled, it's not worth it for them to stay open. There's a lot of economic impacts out there right now, and I think Mayor Tenhaken has done a really great job in making sure it's well understood, because it certainly weighs heavy on my heart every time we have to be making the next policy decisions. What is this going to do to people on the front lines that are working in jobs that they absolutely need to have that job in order to maintain their rent, maintain getting food for their families, et cetera. But yes, there is certainly, and I know we have not had an economist come on board yet. I wish we had the luxury of time to be able to really do that at this, right now, but that's certainly something we always have to be taking into account, are those economic impacts, as well as what you talked about, and that is the toll it takes on our community when people are very sick and ill, through COVID, as well as compounding that with other chronic illnesses that they're dealing with, so.
Makes sense. I guess my other question, and it's probably outside of your realm, but maybe for one of the doctors or from the hospital systems, what does 10 days in an ICU bed cost? I know there's going to be a range, but that's, we get told all the time to ask, what do things cost? I know what it costs, or I've got a pretty good idea.
I honestly can't answer that. I could call our finance office and get that directly for you,
But it's not a couple $100 a day.
No.
It's tens of thousands by the time that you get done. And so that's where I guess I'm balancing some of that. Yes, are there a number of people who are going to end up in that situation? I keep going back to the quality of care that we talked about earlier. And I think we talked about it a little bit earlier too as well, that when do you stay at home too long? And does it cost you more from the financial side of it? Because if we're going to break this down into a monetary issue and the effects to the economy and whether the hospital systems are able to get paid and what insurance reimbursements, and that takes us even crazier places than modeling what COVID does by the time, but to balance those two costs. And again, I've said this pretty consistently with the people that I've spoken with over the last couple of days, is the quality of care, being not able to save people who we would if we weren't full. And that quality, yes, there's a death rate that goes with this virus. There's a intubation rate. There's a, lack of things in between. What scares me the most are those people that we could have helped in normal situations, but now we're in a peak situation and they're not going to get the quality of care that they normally would. And that's not to insinuate that either hospital system would provide inadequate care, but the reality of this, we're going to get to that point, and we're trying to do everything we can to get away from that. And how you balance that in an economic versus the lives of people that are affected by this. So that's me babbling on, and you did a nice job bobbing your head to go along with it. So I'm not sure it's a question. So thank you.
All right, thank you. I'll pass the gavel back. We'll move on to the next topic.
You need to keep it, because I think I need to set this one up too. I'm sorry.
It's off the hook.
Sorry.
Do I get to talk sometime this
Yeah. The next topic, and our final topic is just questions and discussion amongst our council regarding the proposed stay-at-home order. So obviously, we talked about that early on, and the data that we presented today to you all is what's driving kind of the next step I think we need to take. And trust me, it's very challenging for me to say that we should do less right now. And so what I would like us to consider as a council on this ordinance, and the city attorney is going to be talking with me about this. We've ships passed in the night today and haven't had a chance to connect, is if that can be either withdrawn or voted down. But then what I would like to do is have you as a council potentially look at bringing any amendments you would feel comfortable with to our existing no lingering ordinance that would help with some enhanced social distancing measures we could consider. Because based on the conversation again today, the point is, and you heard it straight from the doctors, we're tapping on the ceiling of what they're comfortable with. And so without doing a stay at home, what else can we do in our city to protect the capacity of these systems right now as we move into the next 30 days. So that's going to be the kind of the proposal or the conversation from the administration between now and Tuesday. So that's just me, my opening comments. Marshall, I'll let you lead some conversation on that.
Okay, so do we open it up for public comment after that? Is that our
That's
topic?
kind of the setup. So public input would be now. Yep.
So if we have input on the proposed stay-at-home order, come on up.
Sierra Brewside, Sioux Falls. I just got off the phone with the domestic shelter people. If we shelter these people in more, the violence of domestic is going to rise. We have issues right now because they're in the home. They cannot get away from their abuser. So being a shelter in place is going to cause more domestic violence. And I'm here to say this, and I hope the mayor understands because I don't care what the chief says. The officers are against shelter in place. Their stress level is high. It is getting dropped in their lap. If we start arresting these people, giving them tickets, because you cannot put a shelter in place and tell the police that it cannot enforce a class 2 misdemeanor because they're going to enforce it. I'm letting you know right now that the police is against this. And your chief of police should have been here to testify on that. From upper management to officers, they are against it. They're going from call to call to call. If we drop this in their laps, their stress level is going to go through the roof. We have to consider the domestic shelters here. I know, I'm not going to say of a business because an employee got a hold of me that 2 of their people in their facility had COVID. One is in the hospital as of right now, and the other one is in a hotel quarantining. And the employee texted me on my phone last night and said that they're hiding it. The health department knows of this situation, but if we're going to put all of the businesses that are in place that have COVID, that has tested COVID, we have one particular one that hasn't even made that list. This incident happened almost 2 weeks ago. The person that is in here is still fighting for their life at Avera. So if they want to lie and they want to tell me that it's false, I'll come out with the names of the patients and where this location is at. So we need to put all the lists of people like Deuces Casino and everybody else, and we need to add this facility in it. Because this facility is no better than all the other ones catching COVID. We cannot pick and choose what we're going to put on the businesses and news media here. If we put the shelter in place, riots are going to happen. You best believe it. And I'm telling you, riots are going to happen. Protests is going to happen, and violence is going to raise on the streets here. This is what's going to happen with shelter in place. Please listen to Governor Noel when she said, we are not here to control everybody. We have constitutions here. We're not prisoners here. The H1N1 people died last year of the H1N1. The flu season's coming around. Do we need to wear a mask? Do we need to do shelter in place because of the H1N1? We got to think about our domestic shelter here. The director wasn't here to speak on it today, so I called and reached out to them. We need to think about this because we're keeping our abusers in the houses, our victims with their pimps and their abusers, and they cannot get out because y'all making them so paranoid. And then if they can only go to the grocery store and they can only go this way and they can only go this way, their abuser is going to follow them. There's no way to seek out of this. And we got to think about our police department. I know the mayor don't want to hear about how I'm pounding on this police department, but there's more to come on this. But the police department cannot go to these police calls because neighbors are going to call on neighbors and neighbors are going to call on neighbors, just like code enforcement and health department. They're always nitpicking, and the police is going to keep going to these calls and going to these calls and going to these calls. They are overwhelmed with these things. If we're going to put this in place and make it a class 2 misdemeanor, the mayor and the city attorney cannot tell the chief, don't enforce it when we get police calls. They're going to enforce it. They're going to write tickets and or they will arrest you and put you in a jailhouse. We got to do that. So y'all got to think about that. domestic abuse. Right now, the domestic abuse is at a standstill right now. It hasn't gone up and it has not gone down yet.
Thank you. Come on up.
David Graham here with Crawford's Bar and Grill, downtown Sioux Falls. I've reached out to many of you and appreciate the feedback and the conversations we've had. The stay-at-home order, I guess I'm not too concerned about that, as we've already been shut down as a restaurant for over a month now. My concern is what is going to happen moving forward. When do you guys predict we'll be able to open? Obviously, it's a fluid situation, very difficult to predict. More importantly, the reason I'm here is I'd like to propose kind of a solution. My facility is limited to 10 people. We shut down voluntarily March 17th. Kind of wanted to give it a 2-week hiatus to figure out where this was going. Obviously, that was extended, and once we realized the severity of this, we realized we needed to keep it down for public safety, or keep it shut down for public safety, et cetera. So my thoughts are moving forward here, if we have a 10-person limit for a facility like mine, based off the square footage, there's smaller restaurants that have the same 10-person capacity, obviously they can put them in there and still probably make money. Whereas my facility is about mid-range size, and then you have a Minerva's, so I'm a drop in the bucket compared to the size they have. So I'm wondering if facilities are adequately spread out, if we can't maybe change the 10-person no loitering order to maybe just increase it a little bit based off the facility's footprint, So that's my question. That's all I have for you guys. And obviously, you're getting it from both sides right now, and it's pretty difficult for you, so I do not envy you. I respect what you do, but I don't envy you right now. I'm glad I'm not you, but again, appreciate it. And then I looked at this graph. I might have missed the presentation on the front end of it, but are they saying that we're predicting 40,000 people by June 8th in Sioux Falls, South Dakota, based off this graph? I hope not, but if that is true, I don't know what the data input is coming in and coming out, but a graph is only as good as the data in, data out type deal. Garbage in, garbage out, you get what you want, we can find statistics everywhere, and I hope this is not true, but I missed the presentation there, and respect the doctors and what they do. So anyway, but thank you to everybody, and that's all I've got. Never done this before, so do I leave now? And
Yep, you're good. Great job. Thank you. We'll let the director just fix things here, and there we go. Welcome, sir.
Yeah, hi, Corey Hansen again. Just a business owner in Sioux Falls, but I did like what Teresa said about there's other things we can do, but just the idea that don't go out unless it's essential, right? That's like a little bit softer order than just to stay at home. And in my business, I've been fortunate and blessed, and me as a business owner, I'll be fine. Like, we can ride this out, like my wife and I and family. What I'm more worried about is my employees, and half of my employees, half of them, I've encouraged just to make their lives better. I feel like that's my mission on this earth, and half of them in the last year and a half have bought new homes, their first home or brand new homes. And now they're sitting here thinking, well, Corey, am I going to have a job tomorrow? I don't know. I don't know on Tuesday night if we're open, if we're essential, if we're not essential. And I was one of the people that watched, again, like I said, for all 4 hours on Wednesday night at home of your meeting. And I appreciate what you guys do. I would hate your job, and it's definitely not probably what you signed up for originally, but thank you for what you're doing. What's frustrating me, too, as a business owner right now is I'm getting phone calls from business owners talking about injunctions and lawsuits against the city if and when this new stay-at-home order comes to fruition, and it's just so unknown, and with the PPP thing going through, and I'm talking to my bank and CPAs and just attorneys, and I'm like, I don't even know if I can accept the PPP or if I shouldn't accept the PPP, because if I can't keep my employees, do I have to pay it back? Do I have to pay it back with interest? It's a mess. And I think before we decide anything, if there's anything we can do is just slow down the jets. And I'm so thankful for the hospitals. I mean, my life is blessed. Like I said, those guys, I've had 3 brain surgeries and 5 strokes. They've kept me alive, and I'm so thankful for the medical care we have in this town. And the people. So I just ask if we can just kind of slow down and say, what can we do instead of this next order? Because I think we've done such a good job as a city. I mean, everybody's business is down, but before we just say, hey, you gotta close, because I don't know who's essential. I tried to look that up Wednesday night, and it was the SISTA thing or whatever you guys said, and I don't know what we fall under, and I had a call from, talked to Dustin Hanson from the street department, and he said, Corey, are you essential? I don't know. So if a tree falls on a power line and we can't fix their chainsaws because we're not open, I don't know what the answers are, and I don't know if anyone knows the answers. So anyway, my ask is just to kind of slow down, maybe check a look and say, what else could we do better, a little bit different? So thanks.
Thank you. Welcome.
Hi, my name is Scott Stubbe, and first of all, I want to thank you guys for the work that you're doing here. I had off and on had thought about maybe getting into politics and that, but seeing what you're going through right now, yeah, it's kind of scaring me off. But two, you can kind of relate to the point that I want to make here, because it isn't the things that you expect that get you, but the things you don't expect. That's what ruins your day. So I guess we can honestly say there's not a single person in this room, not a single expert can tell us whether or not we're going to have another Smithfield in this town or in this area. We don't know that. And when we were talking earlier today about, you know, we might be pushing that ceiling, what happens if we have another Smithfield? What happens if we have a chemical car derail downtown and we got to put, you know, the hospitals all of a sudden in the middle of surge have to decontaminate 200 people and put 30 more on respirators, you know? So, you know, and those numbers, those projections, we had some very intelligent folks say they're middle of the road protection. So already we have that possibility that they could be worse, so that we might actually be breaking that ceiling just for planning on that. So I absolutely understand the push to stay the course. I absolutely understand, you know, the economic harm that it is doing to small businesses and individuals in this town. But I really would like the council to keep in mind the fact that it's the stuff you don't expect that gets you. Don't cut our margins too close. Give us a little bit of wiggle room in case there's an unforeseen emergency in this city. Thank you.
Thank you. Welcome.
Bruce Meyer again, and I appreciate the time that we have here to speak. It seems to me like with, you know, I don't want to disrespect the hard work and the good modeling that's gone in. I think that we've had a lot of smart, intelligent people do that, but these models continue to change dramatically, almost weekly, sometimes daily, and I'm really afraid that we're seeing too many trees out there and we're not seeing the forest. When you have so many of these models that just go from 50 million people affected in America down to this many down, and then here in Sioux Falls, aren't there 40 hospital rooms right now? 40 people in rooms right now? Okay, that's after all the infections we've had. And I think if you want to take in the human factor, the protection of life, you have to take in a lot of other things, like the lady said about the domestic violence, how many people, you can throw out all kinds of numbers. How many people have died of meth and opioid overdoses in the last 2 weeks or last month? How many other things that just beyond, you know, that we can't protect every single person at every single point in life. We have not been given that authority or that power or that blessing. So I appreciate the fact that you talked about maybe bringing things down a notch, talking about lingering instead of staying at home, maybe changing this. I would encourage the council, and I hope that God blesses you with the wisdom to see this, that I think we have an opportunity here. If we're the hot spot in America, Smithfield is the hot spot, can't we take that as an opportunity to find the antibodies that might help other people? That's a very, very good, realistic, controlled control group that we should be able to study, identify, and use to the best of our ability to get people back to work, not just stay at home or shelter in place or any of these other things, but go ahead of that. Go beyond that. Like I said the other night, be bold and show us, let Sioux Falls show everybody how we can lead the state, the city, maybe even the country to find a good formula to take that control group find the antibodies, and turn this thing around. All these people that are gonna be out of work, business is gonna be lost. That is a huge human factor and a huge cost of life and liberty too. Thanks for your time.
Thank you. Welcome. Please come on up.
Again, Troy Jones, in business. I'll just tell you, now we're getting a little bit more in an area that I feel really comfortable because of what I do every day. You know, we've got 1,000 manufacturing employees and all of my partners. I got 1,000 manufacturing companies. We don't in South Dakota and in Minnesota, we don't have a single case, nor do we know of their families having a single case. We have some very aggressive practices with regards to gloves and how product goes from cell to cell, and how we have our lunchroom organized and how we do this. And we're not unique. I think that her numbers, I think she builds a good model, but she has some assumptions in there. That number, we got 10,000 now. I'll bet we have 5,000 because our companies are really doing a good job. The one company we have in Sioux Falls, it is not out of the ordinary. Now, I'm also have been the president of a counseling service, volunteer, nonprofit, so I dealt a lot with people who had counseling problems, and my wife's in HR. Plus, we have to manage all these companies. There's two ways to get outcomes, and one of them is a carrot. I think we've done so good with regards, we got a really good opportunity here to do things, pound this down, do the right thing in our community, boom, 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 and we encourage people through leadership and encouragement, as opposed to the stick. And I think the thing is that we have to maybe turn, you want to know what you can do to maybe get these numbers better, is maybe turn it and start these other businesses, which are not me, we're going to be in business. I mean, so our companies are all essential. These people that are not, they need to know when it's going to turn. And they're holding their employees on their staff, and they took that PPPs, which if you close them down, you did that shelter, they just defaulted on a loan. But if you're not going there, but turn it around and let's do more to give them best practices, because this is going to be with us more than just getting to this peak date. It's going to be longer. And so let's give some best practices out of companies like ours to the smaller people on how they can do things to keep the social distancing, satisfy their customers, let their customers come and tell them how to wipe things. You know, like, okay, you guys were on TV and you're doing better now. At my company, you walk into an office, the person walks into our office, we wipe down everything in front of them. They sit down, we don't shake their hands, we wipe down everything when they leave. Customer, supplier, employee. We do Zoom meetings. So the point is that you do these things. I think we can help these businesses by giving them best practices and give them hope that they're going to turn around. And if you give them hope, they will even perform better these voluntary things that you're asking of them. They will help their employees do better. They'll do better at home. They will know to their spouse, we're going to survive. My employer is going to be here. My business is still going to survive. We got hope. Don't throw the hope. So I think if you want to do something, give these people a carrot. Don't slap them. Give them a carrot and we'll get better results. We'll beat these numbers. I know you're going to do it. And we got to go longer than just till May 15th. We got to do this till July. So thank you very much.
Okay, and Bridget, if you could just hold on. Tom's just going to adjust the microphones a little bit. I think so it just picks up better. Okay, welcome, Bridget.
I was wondering how I was going to reach that. Hi, I'm Bridget Myers. Obviously, I own 2 businesses in Sioux Falls. I just want to know if there's some clarification on my business. As you can see, I currently serve on the State Board of Massage Therapy. I'm the vice president. Actually, the lady that stands behind Noam and all the videos that you're seeing, that is who I report to. So the state is telling us that we can still work. And so I've got some confusion there, now being told by the city health that there is, a difference, that they do want businesses shut down. So I think there's a little bit of confusion there with some of us that have state licenses through the state, and then now we're being told by our city that there's changes. The graphs that you showed today, does that include the change with the 65 and older? Because it says that you guys did that on March 18th, so is that including the other change that you added, that added the 65 and older? Because I feel like that was a whole chunk of our population that started staying home. They weren't able to run out and go golf and do those things anymore, so I just want to know if that included that in there. Human factor was brought up too. You got to keep in fact that people are human, and we are going to treat stuff at home, and we're going to take vitamins, and we're going to take supplements. We're going to go do our saunas. We're going to get massages. We're going to exercise. We're going to get out in the sunlight, get our vitamin D, get the things we need to stay healthy. So I know that that does not include human factor, but maybe it does. If you can better explain that, I would love to know that. I know Dr. Fauci's taken some major heat because a lot of the graphs that he gave throughout the United States didn't actually come to fruition in many areas. So a lot of these places planned extreme measures and then it didn't come to fruit. So I have questions about graphs and things like this because some of these states really shut down their cities and they're in serious trouble, and it didn't even end up with 89 people in the hospital instead of thousands that were predicted. I can tell you, today when I was listening to the thing about the cell phone data, I had some big concerns because it said 2 weeks ago we were down and now we're back up. We also had an Easter weekend in there, and I know that some people were making trips to go to the grocery store, get things for the holiday. I know that people probably did do some travel, but we were also around that time told that we could start going outside and we could go to parks and we could take drives and things like that. And I know people, I heard motorcycles out, I heard a lot of things out, so I know that added to those numbers, but those are the things that you want us to do for mental health. And I don't think that we should take that number and use that data against us for this ordinance when you told us to go and take the drives and to go do those things for our mental health. I'm concerned about all the businesses that have already made innovations. I feel like kind of this is a slap in the face because there's a lot of places that have made some really, really good innovations to keep their businesses open. I personally bought a lot of disinfectant supplies. I'm on the last of it. If anyone knows how to get Clorox wipes, please let me know. I'm struggling and I'm down to the last of them in my business. I spent a lot of money buying cleaning supplies for every room to meet the CDC guidelines. And I feel like a lot of people spent money, and if you close these businesses down, now we spent all this money on this disinfectant and things to meet the guidelines, and now you're shutting us down. The strain on businesses has me very concerned. People that are single income, that are single parents, if you shut down their only line of income, many of these loans people can't get. The whole PPP thing's a whole tricky thing. I looked into it, but it was really tricky. And then if you don't follow the guidelines, you owe the money. And some of these people took $75,000 loans. So that's a lot of money we're talking about here. I'm just small change. I'm not a big business. I'm very small. I'm individual. I'm worried about the strain on the community for shutting down the businesses, shutting down any chance to leave your home for things except for essentials. Some families are struggling. And the mental health we're at 34 days, and I can tell you, it's been hard for me. I'm a very social person, and this has been difficult. I can tell you that it's been a month since I filled my car. It went 4 weeks before I had to fill my vehicle, and I drive a minivan. I mean, that's how little driving I have done. I'm worried about the amount of suicides, and I would like to see the data of how many suicides we've had since we had our first case. I think those numbers need to be figured in to the information. Because it is a concern. I mean, the impact economically with people's money and other things. Just one other thing I wanted to, you brought up some of the healthcare systems that were strained, particularly Italy and some of those. Those are socialized healthcare systems. So how are they comparable to our healthcare systems when they are socialized healthcare systems? And the information I've read is they didn't have a lot of beds per population, and that's why they ended up with the problems they did. I also want to know if there's data to support heat killing the viruses, sunlight, vitamin D, things like that. Is there any type of information of things that we can do to help keep ourselves healthy? And I thank you for everything you guys do. I know this is a hard job. Thanks.
Perfect timing, thank you. Welcome.
All right, I'm Bethany Boyden, and kind of piggybacking off of what my mom just said. So I'm a freshman in college, have been ripped out of my life pretty much. I was out in Sioux City, living there, being with my friends all the time, learning how to live on my own, and that all got taken away in pretty much a blink of an eye. And so I struggle with depression and anxiety, and just something for you guys to keep in mind. I know this is hard. I respect everything you do, and I know it's hard deciding what is best for certain people, what is best for everyone overall. but I really think you do need to take into account that kids my age are struggling right now, and I know a lot of other, like, older people are as well, but we had to just completely do a 360 with everything, just going to school, and it's a lot of stress even going online for school and doing all these things, so just keep in mind, yeah, the mental health people, Loveland, Colorado, they just did their shelter in place, and their suicide rates are skyrocketing, and so they now made a change to that last night, and so a lot of times when I get stressed out or really bad anxiety or just I can't be at home with my family, I have a 6-person family, they drive me insane. I need to just get away sometimes, and I do enjoy going to parks and just being outside. So I don't know, maybe opening the parks, I don't know if even that's an option, but just something that kids are allowed to go out and they are allowed to kind of just get things off of their mind and not feel like they're trapped in their house and feel like they're being watched everywhere they go and targeted to see who they're being in contact with and everything. But yeah, thank you for everything you guys do. Yeah.
Thank you. Any other input? I'm not seeing any. Before I go to discussion with the council, I do want to ask the council if you have any more questions for the doctors, because if you don't, I'd like to make sure we cut them loose. Not seeing any. We really appreciate all of your time and
Counselor,
yes,
I do have one that's unrelated to our presentation here this afternoon, but I have had, we heard about ultraviolet light, I think, at our last meeting, and I've had others in my line of business question ultraviolet light and its effectiveness. UV light seemed to be effective against SARS and MERS viruses. Wondering what the studies show with the coronavirus. There's a lot of surfaces that are difficult to clean that are made up of texture. So comment would be appreciated.
Yeah, I can tell you that we've looked into UV light, vaporized hydrogen peroxide, as well as your usual bleach type chemicals and that sort of thing. All of them are extremely effective in killing this virus. We're in the process now of putting up a UV light sterilization area in our Fargo hospital as we speak. And we've been using the hydrogen peroxide vaporization in all of our medical centers, all of our major medical centers throughout the system. But yes, it's quite effective.
Thank you, but I would like to say I don't believe it's recommended that you use it on ourselves or on humans, because it disrupts the DNA of the virus, and it would have the potential to do the same for us. So it's better to be used on different products or surfaces, as I understand it.
No, you're absolutely right. It's best used for personal protective equipment or for sterilization of instruments. It's not meant for human consumption.
Thank you. I just wanted to make that clear.
This is Dr. Elliott. Great question. We currently are using UV light to decontaminate our N95 masks. About 10 minutes of UV light can treat an N95 mask. So we're currently doing that as a method for personal protective equipment extension of their lives. We think we can safely do 5 UV light treatments for each N95 mask. In addition, for a couple of years now, we've been using light-emitting robots in our hospital rooms, terminal cleans for our hospital rooms, in between cases, and at the end of the day for our surgery suites. So yes, indeed, we're aware of the technology, and it's actively used here in Sioux Falls.
Thank you. And once again, I want to thank the doctors for all of their time. Your expertise was invaluable. Thank you.
Counselor Neisert?
Yes, Counselor Brecky.
As long as we've kind of varied off just a little bit into this discussion, I guess I've got one question I'd like to ask the doctors as well. I read, you read a lot of stuff and you want to know if some of it's any good or not. I read that drinking, room temperature water, like 15 minutes, sipping on it all day long was good. And following that with gargling with salt water, because it chases, if you do get if you do have some of the virus, it chases it down into the stomach acid, which kills it. And I was just wondering if, I think this is a positive conversation to have, if some of these things that, are working on a preventative side, or if you, again, have someone in your household that might be bringing it home to you. And so if doing those things actually help. Can one of the doctors address that one? Sipping room temp water basically all day long, so you're just constantly swallowing. If again, you might have someone in your household. I have a son who works in a pharmacy, so I'm just concerned what he might be bringing home. So there's that, and then they said gargling frequently with salt water. It did the same thing, chases it to the stomach when the stomach acids kill it.
So to address that, and I've been asked that before, I've actually discussed that with my infectious disease colleagues as well, and there is no data to support that, and it does not work. However, that being said, it's not harmful. We certainly can do it, but obviously, if it was proven to be a measure that would prevent infection, we absolutely would be endorsing it, but at this point, we cannot.
Thank you. Okay, I think with that, we will cut you loose. Thank you very much. For the City Council, questions, discussion regarding the proposed stay-at-home order? Okay. Councilor Staley, slow today, thanks.
Thank you. Let me say that this whole thing since Wednesday, Tuesday night has really spurred a very high level of awareness, I think, within our community. And I do believe that there is a increased, renewed willingness to adhere to the necessary steps to ensure that everybody is going to be safe in our community. And I also think that the people on the side of wanting the shutdown, the shelter-at-home ordinance, probably are thirsty for information, and having the medical community come forth and tell us that we need to maybe add a 10% reduction on the curve is going to be a hopeful thing for them. Got to realize that we just got the information on Tuesday night, so we've all been digesting what this ordinance really has as an impact to everyone. And Mr. Jones, Troy, I had already written down earlier, and I've been saying it today, the carrot and the stick. So I'm not trying to steal from you there, buddy. But it's coming to me, and I'm always going to take this approach that if we can offer a carrot instead of hitting people with the stick, that's going to be a much more palatable thing and a positive thing for our community. I said to most of my colleagues, I've been saying, let's look for win-win opportunities here. What can we do to minimize the impact on everybody? I am not inclined to impose any kind of fines on our citizens. I know right now we have the lingering ordinance that is going to impose a fine if a business has more than 10 people in certain businesses. I'm not going to put that on our residents. I can't do that. I do think that if we tell our residents we need 10% more, they're going to be with us. They're going to want to do that. We're talking about essential businesses. Golf courses are essential under this. Greenhouses are not. The bike path is essential. Going to buy a car is not. Zambros, you can go to Walmart and get your prescription filled and wander over and buy a book or something, but you can't go into Zambros. They would not be essential. So I think the winners and losers here are very problematic. When we look in the Argus Leader about the list of businesses and facilities that are showing up with the new cases, they would all be essential. None of them are going to be closed down. So I think that the problem that needs to be addressed is working towards helping these bigger businesses, and Troy, thank you, because you or maybe it was you who said, you're really wanting to get a grasp on what you can do to help. I think this is where we're going to be going. But we don't want to penalize the smaller businesses either. So I was hoping, 2 weeks ago, I brought up an amendment to the lingering ordinance that was going to meld into it the proclamation that the mayor made, talking about the 20% occupancy threshold for patrons. To me, it made sense to take the 20% number and add employees to it. So
Has joined the meeting.
So we are asking businesses to scale back to help just with that social distancing. So I tried to put that in 2 weeks ago, but it was too big of an amendment to fit, and it was going to cause a gap in there from what we had to going to nothing for a week before this first reading came through. So I have been talking to some of my colleagues about the possibility of adding that to it, and I know the mayor, and since we're having this discussion about where we could go, I don't know where, with the current ordinance, I don't know what could be gutted out of that as an amendment to make it palatable. So we're kind of going back to the lingering one. So I was wanting to add some kind of language of what the mayor had with the 20%, but last night Stacy Koistra said that that might be too big of a change, and again, we're going to be stuck with having nothing in the lingering ordinance for a week as we're trying to, well, actually, our next meeting is in May. So Councilor Neisser and I talked last night about a possibility of a resolution, which is, of course, not binding, but if we could set up some strong recommendations from the council as to what we want to see in the community, that would be separate from the lingering ordinance. So, I mean, I think what we need to do is we need to do something. I think the public wants to see some kind of action, and I think that 10% thing does need to be addressed. That we say that we want to cut that curve. I think responsibly we say we're going to cut that back by the 10% from the 25% we're doing. We're willing to, let's work together to make it 35%. What things can we do? So this is really a wonderful experience for us on the council because we've been doing a lot of collaborative brainstorming to say, you know, we've heard these things from the public. How can we put this legislation together? So that's, right now, I think we could get a resolution on as new business next week if that's where we want to go.
Very good. Other, Councilor
Amy
Erickson.
Elliott has left the meeting.
I will just chime in, and I know after our meeting, there was a handful of us that talked to constituents at a safe distance, I'll say, and had some really good conversations as far as what could be added and done. And I do like the idea of the resolution. I'd like to see that when possible, of having a statement in conjunction with the mayor's proclamation of just reiterating some of those things. We won't run into the substantial issue then. And I think that it will ask for that voluntary compliance for us to say, this is what we really want you to do. Here's what you should do. Because people are doing it responsibly. I think that sometimes when we make heavy-handed decisions and force people to do things, they maybe push back a little bit harder than what they would if we said, will you please do this? And just curve that because like Mr. Graham was saying earlier, we've got to get these people back open. We want to prolong this and make sure that the healthcare systems are adequately employed and caring for people, but we've got to get people back working. We just have to. People can't make it for many, many months. And while balancing all the other things that come with it, we have to maintain that. So I would love to see that, Counselor. I'm glad you're working on it. I think it's certainly a viable option for us to consider. I know the question was asked, and if I can ask you a couple questions, Mr. Mayor, as far as bringing some amendments based on the conversations in the EOC and those inside baseball conversations, what amendments do you want to see? I mean, I guess I want to flip it back on you and say, you're the one in the EOC. You're the one that are having all the conversations, and we get daily updates, and you've been phenomenal at communicating information to us, and I'm very grateful for that. But having those conversations daily, what are those things that you're recommending or suggesting based on that?
So I think it's important for us to remember, as the people setting the policy, is to set policy that has the maximum efficacy, okay? And so what you just heard today over the last 3 hours is that we're hitting this line of capacity. We're at the top. Anything we can do to help with mitigation will give them, I think, desired breathing room. So what could those be? Well, where are the problems? Where are the issues? The issues are where people gather en masse. Okay? The issues are, to Troy's point, he's talking about some businesses that are taking the right steps. There's a lot that aren't. Okay? And so what do we have to do do we need temperature checks that are required at large businesses for employees going in and out to ensure that if an employee is running a temp, they're not allowed in the facility where there's 100 or more people already in there? Do we need to have people wearing masks in Hy-Vees, Lowe's, Home Depots, have that be in ordinance? Do we need to look at some of those things that aren't restricting business? We're not telling a business, listen, you can't operate your manufacturing facility, but it's in ordinance that you need to check temps, and anyone below this needs to be turned away. I mean, those things aren't restrictive on business. There's a staffing protocol. It sounds like we have some, in a lot of businesses that are doing that already, are doing it without nurses. You don't have to be a nurse to check a temp. Someone just checks the temp at the front desk and you go in or you don't. So those would help. Some of those measures, I think, would help in not taking the full stay-at-home ordinance, because I think it's pretty much decided we're either voting that down or we're pulling it. We're trying to figure out if that's the way to do that. But is there amendments that can happen to that no lingering ordinance, or does it have to be a new item that we notice and bring forward? So I don't have all the answers. Those are a couple that we've talked about to ensure business compliance, because all we can have done right now with the large employees have asked. I've had conference calls with the CEOs of probably the 50 biggest employers of this city right now, and have begged, pleaded, and done everything I can to get them to comply. Well, I'm still getting whistleblower emails all the time from employees at those companies saying, my employer still is not doing this. My employer, so I don't know what else I can do. And some whistleblowers are at some pretty substantial companies that should know better. And so that's the challenge we have right now. So I'd love to figure that out with the council between now and Tuesday. If you guys feel that there is something that we could collectively agree on that would help us move the needle.
And would those be considered, I hate to ask this question, would those be considered substantial changes? Are we bound that we can't bring those? We're in a time now where we need to make game time decisions. And so I know you're my attorney and you're going to advise me, but at what point can I say, thank you for your advice, but I'm going to make these decisions for the good of our community, and then you get to defend me if we're sued.
At no point will I advise you to not follow the law.
And I understand that. You will give me the advice, and we as a council can decide if we feel this substantive amendment, maybe we don't feel it is, and so we make those changes. I don't know. I don't want to get into that shenanigans today because it's been certainly a difficult point for us to get to. The other things, I've gotten a handful of whistleblower emails too of companies, and did early on. Many of them were having large parties and kind of calling them. I had somebody send me an email and saying their neighbor was having a COVID party, which is really ridiculous. But I picked up the phone, I called them, and I know, Mayor, you've done the same thing, as well as a lot of us have, of saying, hey, what can we do to impact this? How can we work together in making sure that your employees feel safe, and that we're really making sure the community is also safe as these people leave. Not to be a little cliche, I was watching the Today Show this morning, and I saw a really great story on one city that was using they were using police, which I don't know if that's the best thing, but we have a lot of city employees that we're trying to repurpose too, that need some jobs and things to do, and we're paying them, but can we use them to do education? We don't necessarily want them out in the public and congregating, but this city, what they were doing is they were handing out masks to people that were walking into big box retailers, saying, when you go in, here's a mask. And people were extremely grateful for that. Can we do that as a city to be a community partner in some of this? Partnered with making calls and really just saying, okay, guys, we need that extra 10%. Be a good neighbor. What can we do to get that extra 10%? Because I'm confident that this city will react based on our leadership. I really do. If we cool, calm, collected, ask everyone to say, look, the goal is to just not overwhelm those hospitals as we get closer to that curve. What can we do to make sure that we're doing that? And seeing those results. We've heard yesterday with the projections coming out of the governor's office that curve was for the state, I will say, not for the city, is cut in half. The projection is more of a mound, and so that's great news statewide. We're seeing a higher peak projection here, probably because of our population and just higher density. But what can we do as a city for that, to making sure we're moving that needle just a little bit more to ensure the hospitals don't have to operate at capacity?
Councilmember Neisert.
Let's go to the phone and Councilor Brecky.
Thank you. Since we're kind of in a green light thinking mode, in a collaborative mode, what I would kind of toss out, there's a couple ideas. One thing would be, again, I think that really the momentum from discussing this and the people's concern about us adopting it has really raised the awareness that if we just really work together with our community, just like you did with the tornado, Mayor, I think they'll come through for us. If we tell them we need 10% and we need them to just go out when it's essential, and then if we were to consider passing a resolution with a list of strong recommendations that really we could collaborate on it, but the best list would come from you and Jill Franken, from the EOC. Here's the things that we think would really make that difference. Put those, on the resolution, and then perhaps consider an emergency appropriation to fund an advertising campaign, utilizing PSAs and just advertising capacity to just, really blitz, saturate, our TV stations, for just a short period and just tell the public what we need them to do, tell them what we want them to do, and whether it be a combination of paid for and PSAs, and even when you're doing your press conferences, just you recite the list over and over and over again and watch the figures and see if it works.
Thank you. I'm going to go to Councilor Staley, and then I'm going to check the phones again.
Well, and in this discussion this intense discussion since Tuesday, we did have this, and I'm actually calling it the gasoline ordinance. Because it's like, you're going to start the gas stove to cook something, and then you just pour a bunch of gasoline on it, and that's really what happened with our community with this thing. And I was of the mindset to take that ordinance and put it on the back burner and defer it, and say to the public, hey, we've got to work on this, or this thing's going to come back again. I mean, I know nobody wanted that threat hanging over their head, but especially, Mr. Mayor, when you're saying that you're having conversations with the 10 largest companies in our city, and there seems to be kind of a question as to how these practices within their employees are being implemented. Councilor Neisert, were you going to say your idea about the hotline?
Well, I don't know that I can, since I'm now holding the gavel, but.
Well, then if you don't, Councilor Neisert had an idea about having an employee hotline where they would somehow be connected to an entity that they could report that there's a problem, and then it would be followed up on. If the businesses knew that they were going to have some kind of oversight, that might help take the numbers down as well, just to make sure that we're all playing by the most intense efforts possible for the 10%. So my 2 cents on that.
Thank you. I'm going to go back to the phones. Councilor Kiley or Sale, if you're still there, do you have any comments or questions?
Yes, this is Counselor Kurt Sale. To the previous question for Counselor Staley, that entity is existing. It's called the South Dakota Department of Labor that regulates employment and labor situations. That's all I have. Thank you.
Counselor Neitzer?
Yes, Counselor Brecky.
Just one more thing that we could consider doing. And I've discussed this with the mayor before, and at that time it wasn't, a path we want to go down, but it's a path we can consider here as we have this discussion. What we could do, is adopt the ordinance, but delay the implementation date and put a sunset clause on the ordinance. So the ordinance would sunset in 2 or 3 weeks, and the delayed implementation would be triggered by a recommendation to execute the ordinance by the Board of Health, and then the mayor could execute it by executive order. And so that would, that would allow us to do something today that if these volunteer efforts don't work and we see the hospital, seriously needing it, we wouldn't have to go through the delays. But, absent the mayor actually implementing it and executing it through the recommendation of the health board, it would just sunset and go away. And that could be, made to happen like in 2 weeks or 3 weeks. So it's just something to think about, that would just be hanging out there. I just thought about having it be triggered by the, by the health board, but it also could be triggered, based on a resolution by the council. We could also say, if people felt more comfortable, having both entities, say, okay, it's time we have to do this. So just another sort of procedural way that we could kind of leave our options open if things go south. Because we've talked about the models and how they might be less. They could also be wrong on the other side, and they could be more, too.
Okay, thank you. I'm going to go to Counselor Erickson.
Thank you. I just want to comment on Counselor Brecky. Thank you for thinking outside the box and trying to come up with other ways. For me, I will not support that in any way, shape, or form. The uncertainty for businesses is just too large, and I'm also not interested in taking any authority away from this council. That's just where I stand on that. Thank you.
Counselor Staley.
So for our city attorney, this is the question. Let's say that something that it totally spikes out of control. And we've got this huge amount of death happening, and it's an emergency situation. And we're at that point, we say we're going to have to take action. How does that look? How quickly could that happen?
Well, I'm going to give you a legal answer, Counselor Staley. If I was in court, and I don't mean this in a bad way, but I would say objection calls for speculation. There's a lot of, in a hypothetical, it's hard to advise because, there are a lot of pieces to that if you're talking about procedurally what we would do.
Well, could you, is there something in place where you'd have to have an ordinance that would be applicable immediately?
Right. The same rules of procedure that we're functioning under now would also apply then, because there's, the clear body of authority regarding first and second readings. The mayor, under his declaration of emergency, has the ability to call a special meeting, not unlike this one, to get something in the hopper, but we'd still go through that first and second reading process. So, at the city level, you talk about resolutions, that's got a little different timeliness component to it, but wouldn't, again, be the force of an ordinance, it would be a resolution. So, it's a good question as far as if things get really urgent, but, the law applies the same from a procedural point of view.
Thank you.
Counselor Starr.
Yes, thank you, Mr. Chair. To follow up a little bit on Counselor Staley's comments, I think, as far as I can tell, we're in the middle of the pandemic. It's starting to spike. We've done everything that we can do as a council if we pass this, or if we move forward past this time. When you look at the modeling dates and things, we've put everything into place that we're going to be able to do in a timeline that's effective to make a difference. We can try to do PSAs, we can try to do all of the other things. We're past it now. You know, by giving up this week and punting basically on Tuesday and asking for niceties from our community and expecting people to do what they're going to do, we're not going to do anything significant that gets us from that 25 to 35% right now. We can argue about the model and whether we'll see the modeling, but with the data we have, by not acting now and being decisive, we're basically punting it. And I think our residents of our community told us that's what they want us to do. At least half of them that have contacted me have said, hey, we're individuals, we'll do our best, we want to move on. We're not getting a demand from the public to tell us that we need to do more. And I think we're missing an opportunity, and I think when we look back, we're going to be disappointed that we didn't take stronger action. But at this point, there isn't anything that we can do that's going to move this spike that isn't already in place. There are things, again, that we can do in emergency situations and stuff, but from the preventative side of it, this is our window of opportunity. And like I said, the emails and the people that have reached out to me and a majority have told us they don't want us to do anymore, that this is as far as that they're willing for us to go. I'm disappointed by that, but I think that's the reality of where we're at. Thank you.
Thank you. I'm going to go to Councilor Kiley on the phone.
Thank you. Well, I'm not certain that we have necessarily missed our window of opportunity yet, but I know that I have certainly talked about that in the past, that we do want to be proactive versus reactive. Because if you're reactive and you wait until you hit that exponential growth point, then you are fighting a losing battle. I think the next several days will still tell us quite a bit. I'm encouraged with what has taken place just in the last two, that the growth of infections, while it's still growing, it's not growing at the rate that it was 2 days ago. So let's see what is going to happen over the course of the next several days and even beyond the Tuesday meeting. But I do just want to caution everybody, the public, that this does not in any way, shape, or form indicate that we should take our foot off the gas. We have to continue to self-monitor and social distance to do our part. So we just need to continue to be vigilant, and we need to continue to watch the data as it comes in. And the data includes not only the infection rate, but the hospitalization rate too, because the hospitalization rate obviously follows the infection rate. We can't just look at the infections today because as soon as it's determined that you are positive, it's often many days before you go actually into the hospital. So I just want to caution everybody that we need to be vigilant. Thank you.
Thank you. Oh, yes, Director Franken.
I just really want to make a couple of comments. One is I used the word optimistic earlier in the presentation when we were talking about the data. And I want to be really careful to have you understand that my optimism is that I feel at least much better about where we are headed as a community in terms of our infections, our rate of hospitalization, et cetera. I was far, far more concerned a week ago. And so when we started looking collaboratively and got our GIS folks involved, I started feeling at least a sense that we are seeing a pathway where we've got a better match of what the capacity is in Minnehaha and Lincoln County, or our capacity of our health systems to meet the demand. But I also want to tell you, and I feel like I have to, that I think we do need to do a little more than what we're currently doing. I think we need to add to the No Lingering Ordinance some additional measures, some of which Mayor Tenhaken was talking about. I think that's imperative. I do think that that's very necessary for us to get a little past that 25%, because I think that 25% right now is a generous perspective on where we're at with our social distancing. And I think we need to do a little bit more in policy to ensure that we can have the resources needed across this time period. So thank you.
Thank you. Councilor Staley.
Tom, do you have that? Jim David was kind enough to pull this up. So this is what a draft that I have, but again, it would be wonderful if the mayor wants to add something to this. Before we get into this, were we talking about patrons coming into a business wearing a face mask, or the employees wearing a face mask?
It's not an agenda item.
Mr. City Attorney, I think he has something he wants to.
Yeah, I'm sorry. I didn't, this resolution is not on the agenda, so I just want to make sure that,
But I thought,
don't get too
we
far.
were talking about where we're going from here.
Yeah, it's discussion and
So
questions
this
regarding the
could be
ordinance.
a possibility of where we go.
Well, the agenda identifies it as an ordinance. I mean, if you had some things to talk about, but I don't want to present a resolution to the community that hasn't been noticed for discussion, so.
What if we just call it some suggestions? Well, I mean, because the mayor already said a suggestion that he already referenced the resolution.
Yeah.
Well, he was referenced, okay, let me back up. So let me say this isn't a resolution, maybe, I'm just going to talk about this being an amendment, which apparently we can't do.
You can I think you can discuss the substance. I just don't want any confusion that there's a resolution being discussed this afternoon. That's not part of the agenda. So if you're talking about, if it's related to the ordinance and adjusting from the ordinance.
Well, I would like to, well, this is all kind of in the air. I mean, this could be an amendment then.
Okay,
Maybe
possibly.
This will be an amendment. Well, we got to find the way to get it to where it needs to go next week.
And I think there are options for that. I just don't want to stray outside of what's been noticed to the public.
Okay, I'll stay in the box. Okay, so anyway, something I was thinking is a nice statement to make to the public is, whereas the city council and the mayor deeply appreciate our citizens as essential, whereas the city council and the mayor deeply appreciate the efforts that our citizens have put forth to mitigate, got to separate those two words, forth to mitigate the spread of COVID-19, whereas the city council and the mayor deeply appreciate the sacrifice that our employees are making to keep our citizens serviced and safe, whereas the city council and the mayor recognize the constitutional rights of every citizen, whereas the city council and the mayor want to keep all patrons and employees safe, whereas on March 11, 2020, the World Health Organization declared COVID-19 a pandemic, and whereas on March 12, 2020, the mayor issued Executive Order number 218 declaring an emergency to address the novel coronavirus COVID-19, and whereas on March 13, 2020, the governor declared an emergency in the state of South Dakota in response to the COVID-19 pandemic, and whereas on March 23, 2020, the governor issued Executive Order 2020-08, setting forth guidelines and recommendations regarding personal, business, and health care precautions to be taken in response to the COVID-19 pandemic. And whereas on March 24, 2020, the governor announced that she is recommending that all K-12 schools in South Dakota remain closed until May 1st, 2020, and whereas on March 24, 2020, the Sioux Falls School District has closed all K-12 schools through May 1st, 2020, and whereas of 12 o'clock noon on April 16, 2020, there are 1,065 confirmed cases of COVID-19 within Minnehaha County, and, okay, well, we got a bunch of more things. These are just repeated things. Let's go down to now, therefore, it be resolved that the city of Sioux Falls, South Dakota, and we could talk about stay at home. That's what the mayor already, these are all things the mayor had talked about, which are very good. But this would bring the council into the recommendations. And then, Jim, let's go down to where does it talk about the 20%?
It's the very last. Section business at the end.
Businesses. The last section down there. So everything else here is, I believe, what the mayor had said. But section 5, businesses not bound by the limitation of 10 or fewer patrons. as originally set forth in ordinance number 2029 should, whenever possible, limit their patron and employee occupancy to no more than 20% of their posted occupancy and institute a safe social distancing strategy for employees and customers outside of their place of business waiting to enter. Now, on there, we could absolutely, we wanted to say, I mean, just brainstorming what things are going to be beneficial, that employees shall wear face masks, employees shall be having their temperature taken, if that wants to be in there or not. I don't even know how this is going to look how this gets implemented. But I will say, as far as the face mask thing, I don't think I would not want to mandate that citizens have to have a face mask to go into a business, because some people won't have access to that. Maybe some people don't feel the need. That would be problematic for me.
It sounds like I maybe have a little latitude, even though I'm holding the gavel. So I do want to ask if this is something that we have been batting around overnight. Is there any input that the administration would have, perhaps a health director, on whether or not we're talking about things that would maybe get us a little bit more bang for the buck? If our thought about the 20% of posted occupancy applying to both employees and customers, because right now it only applies to patrons in the current proclamation. Has that been thought about? Has anybody batted that idea around if it would help? Because it's just something that we've thought about. So.
And remembering, if we did do this, it would be non-binding. It's more of a strong suggestion, so there's no enforcement piece to it.
Yes. Yeah, and the word should is there, so yes, it's a strong suggestion. Yeah. And without knowing how, I have an email from Fire that I haven't even read yet that talks about occupancy and how they calculate that, whether that would change anything anywhere, and I don't know, so.
When we've talked about our no lingering ordinance right now, businesses are expected that if they are operating and they are of those businesses that need to maintain 10 or fewer customers in their business, that we haven't regulated how many employees are there, but we have said they should be maintaining social distancing practices and good hygiene practices. We've got a list of things in the ordinance that asks them to do. I would say it would probably be my recommendation that we probably mirror that and do something that would be 20% for their customers in those particular businesses, and then put in the statements like the no lingering ordinance around what they do for their employees, similar to what's already in the no lingering. Does that make sense? So you would treat these businesses' employees the same as you would in the no lingering ordinance, how they're treating the employees, which is we're requiring or asking them to maintain good social distancing practices and good hygiene practices to mitigate the spread within their employee pool. But we aren't telling them how many employees they can have at, say, a restaurant does carry out. If it's a large enough restaurant with enough carry out and delivery and or drive-through, whatever, that they have more than 10 employees, we're not telling them to have no more than 10 employees. And I would say the same would be true for this one, but we are asking them to maintain good social distancing. I personally would I think it'd be something we could consider this as actually being, something that could be in the no lingering ordinance, that we put some person instead of just in a resolution. We could think through that and see what that would look like.
The problem with that is that then it turns into, well, unless I see our attorney is gone, but then it would make it would put another week. Well, it would either have to have a special meeting to approve it, or it goes to May.
Well, you could start, if you're asking me a question, if that's all right, you could start possibly with a resolution and then go forward with the ordinance to mirror that down, you know, at the next meeting. You could notice next week. Oh boy, I'm venturing into Stacey Quaster territory here, but you could substantively change the ordinance next week to include such things as this, and then also pass a resolution next week. So you at least have the shoulds going forward, and then you could get the shalls, you know, in ordinance and adopted the next week. So.
That's excellent. That's what I was thinking. Well, the other thing is that we're talking about Lewis Drugs. Some of the businesses are doing a great job, like some grocery stores are one-way thing. I mean, so do we want to somehow put that into a resolution for sure, because that's a suggestion, but just giving direction to those places that would help. Like, I know Walmart is kind of taking you in one at a time. They're not letting too many people in at once, I think.
They have like a clicker.
Yeah.
Track of people in and out.
I mean, that would certainly, isn't that, because to me, part of the problem is when you have these big, like the mayor said, you got these big groups of people together. How can we legislate that? You're right in time. We're talking about how we can. Jill just said that.
Uh-oh.
Jill.
Well, no, we're talking about how we take this a resolution wording and put it into the ordinance, the lingering ordinance, and then that's a time issue, isn't it?
I'll take the heat on this one. I had said perhaps if there were, like, for example, section 5 here in this document that's before us, if that was something that we felt could be in the no lingering ordinance, for example, could a resolution be passed with these are shoulds, and then at the same time you're actually putting forward a first reading of an ordinance. So then the next week that ordinance is passed, so at least you have a resolution stating the things that you want to put into a future ordinance, which would be then first, right?
Yeah, I mean, the what's commonly colloquially been referred to as the no lingering ordinance will be presented on Tuesday. If you wanted to bring a separate ordinance for first reading on Tuesday, whatever that content may be, that could be presented. If in the meantime you wanted to put a resolution together to be presented, you know, with timely notice for the agenda for this coming Tuesday, you could do that as well.
Were you suggesting you would take the no linger ordinance and you would basically put it in a resolution which we could adopt, and then you would amend the no linger and then defer for
No, and I know, I'm sorry if I'm confusing.
Okay.
We have the no lingering ordinance.
Mm-hmm.
If we wanted to add some things to that, then it sounds as if that would need to be a first reading if it was substantive.
Mm-hmm.
So I'm just suggesting if we add those things, we require masks in certain situations. We require maybe things such as that section 5, for example, those types of things. That could be then a first reading of an ordinance. But at the same time, if you wanted to, you could resolve and have a resolution that says, we want you to start doing that now as of Tuesday next week, so we're going to also then make sure we adopt that as ordinance the following week.
I follow. I'm going to go to Councilor Erickson in a second, but I do want to ask, the one thing we did have the word should in here, and that was, I'll just tell you, for me personally, the one thing I do worry about is I don't know how every business operates and what the ratios of people and stuff. So my concern was getting in a bind where I've done something where there's a very legitimate reason somebody needs 24%, you know, of the occupancy of employees, and they're still doing the right things and distancing, and now I've messed up their operations. So we got to be really careful about any of this stuff.
And I think you would want to, I'm sorry, you maybe weren't asking me a question there.
Oh, no, I'm looking for your input. Yes, please.
I think you'd probably want to look at, again, those SISA businesses and make sure that, you know, you're speaking to those differently than those. We've got enclosed retail spaces, but there are other types of retail, et cetera, that you might want to then put that 20% towards.
Okay.
Make a difference. I think everything that we would want to do would really actually move the needle instead of just putting some kind of window dressing on what we're trying to accomplish.
Exactly. I don't want to do something that just feels good, but it doesn't actually move the needle.
Well, and
Yes,
just on
Councilor
that, like right now, Menards, Jill, if you want, Menards doesn't have any limit, right? I mean, that, it can be packed to the gills. So we're not even, these are things that.
Yeah, that's correct. But several of you have said, we've had some really good compliance voluntarily to really try and mitigate. The issue is we don't have it in law, we don't have it in ordinance, and so are there ways that we could do that can just ensure that all businesses that maybe aren't yet could also comply with those particular requirements.
And still stay in business.
Mm-hmm. And still stay in business, yeah.
Councilor Erickson.
Okay, so I want to kind of piggyback on how we've been talking about the businesses, and I know we don't want to get in the business of regulating businesses, so to speak, and I know our attorney has been very strong on that. We don't want to do that, and so we can say a lot of shoulds, but I want us to be very careful that, in my opinion, government is not the answer for mandating heavy things, but we want to give them the tools to making sure that if they make these changes, they will see some benefit if they're so inclined. And so I say that carefully. One of the things that we've seen too is a lot of the businesses have had to shut their hours. And so now we've taken all these customers that visit in a 24-hour period, and we've condensed them to, I don't even know what some of the grocery stores go to, but maybe say 7 a.m. to 10 p.m. or something like that. And so I think that is also a strain on having more people in there, and so it would be wonderful if some of them could go back to 24 hours, but I know we can't mandate with that. The other question I would have, and maybe for on Tuesday night, Stacy, if, and maybe off the top of your head, is we're talking about the lingering ordinance that we have in place, but we also have a loitering ordinance in place too. Does any of that play into what we're already doing with you can't loiter on certain properties and things like that? Is there a way that we can softly educate people? Because that does currently exist in loitering. Not to go down a whole different bunny trail, but this is our time to answer questions. And so I apologize if the night's getting long, but this is a serious conversation to be had.
This is a serious conversation to be had, but this is not the only time we can answer questions.
Right. But it just came to me now. So that's why I say I throw that to you and we can have the conversation on Tuesday. I'm not totally putting you on the spot, but just something to consider how those kind of companion each other.
Yeah.
I'm going to look to the phone in a second, but I'm going to go to Councilor Staley as well. One thing I want to just make sure I mention before it slips my mind, it was brought up earlier, and hopefully I'm staying on topic, is that there was a question about hotlines and things like that. I do want to recognize that we actively have Luann Ford and Jeff Eckhoff leading up a team where when calls are coming in, they are going to the health department, they're going out and they're inspecting, and they are doing. I don't think they've had to write a single ticket because I think they're getting compliance, but I did want to recognize that. They are doing that work, so it does exist, and so, but exactly what number you call, I'm not clear of, but just so we're on record. Does anybody have any comments on the phone before I go to Councilor Staley?
They all hung up.
Yeah, they may have, go ahead.
I think you said no.
Oh, that was a nope, okay.
Nope, no comment.
Thank you. Okay, so I'm going to go to Councilor Staley.
No, okay, Councilor Erickson, just to go back to the regulation on businesses, we're already doing that. The lingering ordinance is putting stipulations on a business.
Oh, yeah,
We've already passed that, right? So I guess I've been thinking, why are we can put it on these smaller businesses, 10 or less, but the big business gets to have at it whatever they want. Why are we doing that?
Good question.
I mean, that just is.
That's actually, that's not a reflection of what the law says. It references enclosed retail businesses, and the definition are in there. So there isn't a small business component that has these restrictions, and a large that gets to do whatever they want. I would just refer people to the language of the ordinances themselves.
Well, I understand, but we passed an ordinance that's going to dictate how a small business operates, and some of, and
Again,
also.
the delineation there is not small business. It's enclosed retail businesses. It's defined in the ordinance.
How about if I say smaller?
No, because there are enclosed retail businesses of significant size that are also included in that.
Smaller employee base? Okay.
No.
Okay, but that also, it seems to me that the things that are, the entities that are having the biggest problem are the bigger ones. We're hearing from the bigger, and whether it's the retirement home or Wells Fargo, First Premier Bank. I mean, it's hitting everybody, but that's within them. So I think it's a prudent thing for us to be looking at ways to help them.
And again, if I hope I can as chair, I do wonder if there is a call center and maybe they have, I mean, do we have any enforcement or any levers right now we can pull? Have you run into anything where you've seen something but you don't have a lever right now? You know, so. Well,
yeah, for sure. You know, and I'm, again, whistleblower situations, and I'm not going to out people, but there's healthcare facilities, none that were represented here, that should know better on practices that they're employing right now, that they should be doing some things very differently. And so it's hard for me, you know, all I can do is say, you shouldn't be doing that, you know, you should know better. And some of that's just going to happen. We're turning this nanny state where it's like people are tattling to me all the time on businesses. I'm so over it where people are, you know, outing their employers. At some point, we do have to just rely on the employers to be doing the right thing. But
okay, I'm looking for other ideas. I will just say for my part,
it seems like to me, there are a couple simple things. I think people should be getting their temps checked before they go into a large employer. And I think the healthcare organizations, we could set up a task force that could help with that. So any employer could reach out to us and say, hey, we want to do this. Can you help us? And we would say yes. And we would find a way to do that. We'd get them the equipment they would need to do that. You know, the temps today isn't the thermometer under the tongue for 10 minutes anymore. I mean, you can get the temp like that, and we can set some protocols for them. And so, because again, where's the problem at? The problem is at a facility where there's 100 employees in a 30,000 square foot warehouse that are working alongside each other all day, and they got a 200 square foot break room where they're all congregating over lunch. So those are the situations that will help us in this. So if we feel it's too heavy-handed to say to a business, listen, if you're 100 employees or over, we're gonna put an ordinance during this time that temperature checks are required at the door, the main entrance of your company. It takes 2 minutes. If that's infringing on people's rights and they don't want to take it that far, then we're really left with nothing at that point. So if those are the things that are going to, but that's substantial enough that we can't just add that to a no lingering ordinance, because that's a totally different can of worms, and we may have businesses rise up and say, no, we don't want to do that either. So, and I think someone said it, again, this is all blurring together, but the window of efficacy is closing quickly here. I mean, this was kind of a Hail Mary, you know, with what we brought forward this week, not knowing what our data was going to look like and what we've seen in the last 24, 48 hours with some of this. So, gospel according to Paul, but that's kind of where we sit today.
Thank you. Other thoughts? It's been a marathon, but it's been really good.
The last thing I'll say, can I say
yes,
one
please,
last thing?
Mr.
We
Mayor.
could also consider taking the CDC guidelines and simply putting them into ordinance for a period of time. It's not us making it up. It's like CDC guidelines. The CDC guidelines recommend some of these things I've just said to you all for businesses. So it's a buck passing maneuver where we just say, listen, if the CDC is doing this, then businesses should be doing this. And again, I don't know what all those are. They're out there. You know, Jill will be able to speak to some of those. So that's another consideration.
So are you proposing that could be put together on Tuesday?
I'm really not proposing anything because I don't know. I'm just, for conversation purposes.
Well, I mean, it's either Tuesday or we wait until May, whatever that is. I mean,
We'd have
we
we'd
can
have
always
a
call a
special
meeting.
meeting for sure, yeah.
well, if you're, if somebody's willing to call the special.
Yeah. So that's what we have to work out as a council over the weekend. I think we need to adjourn this meeting. We got some work to do to figure out if we want to get something like that over the weekend, if we could find some unity to do something like that, or if we're going to be in a position of comfort with just saying, this is where we're at, we've tried to do all we can, and, let's let the chips fall.
Maybe my last statement, I'm open to discussions over the weekend. The only thing I want to think about and be a little cautious about is that if we come up with something and we put it on as new business, even though it's not binding, we're putting in some new regulation really quickly without a lot of notice to the business community. And then once we put it in, and then it's in for the 5 days, it's going to be kind of hard to potentially vote against it. So I could potentially see just passing the no linger ordinance and come up with something and do a first reading and then do a second reading so we can have plenty of public input and really deliberatively think about it instead of doing something quickly. Just food for thought, but we'll talk about it.
You saying instead of a resolution then?
Yes, potentially. That it'd be just a first reading. You'd have the no linger ordinance and a first reading of potentially something that we come up with. But that's just one of many options. So with that, I'm going to adjourn this meeting. Stay safe and have a good night.
Thank you.